Oh, I sent it to you. Did it not go? Did I send it to Adam Peterson? Oh my God. Adam Peterson, did you get a presenter's agenda?
I don't think so.
When did you send it, Anna? Oh, here, maybe it is. Yep, there it is. I just haven't gotten to it. It was at 11. So I am the welcome part today. So look at that. I led into it and it looks like my instincts were correct. So welcome, folks, to the March System of Care Advisory Council meeting. We're going to start with objectives for today's meeting. We'll do roll call for members and talk about our group agreements as well. So, um, just kind of reminders, right? Our shared commitment to system improvement. We're going to ground ourselves in that. We're going to hear from subcommittees centering around folks with lived experience. We've got our guests from OHSU coming to talk about the system assessment and strategic planning. Public comments at 2:40 today. We've got the GARE racial equity review on the System of Care Advisory Council Omnibus Bill. And then we're going to discuss the Omnibus Bill draft, talk about next steps for hearings, testimony, amendments, and all of that. So we're going to stick pretty tightly to the agenda time today because we got a lot to get to. So, Annette, go ahead.
Okay, roll call for our council members. I'm going to go by twos. I'm not sure who is not going to be here, so I'll just call the names. Allison Stark and Sonia Little Deer Evans.
Here. Allison Stark's here.
Sonia said she had to be in and out today, I think, so she's excused for the time being.
Okay, great, thank you. Jackie Serrano and Sandra Santos.
This is Sandra. I'm here. Good to see everyone.
And Jackie's excused.
Robin Henderson and Anderson Du Bois.
This is Robin. I'm here. Thank you.
Anderson's also excused. He's still on paid parental leave.
Kyle Johnson and Adam Peterson.
That's Kyle. I'm here.
This is Adam. I'm here.
Thank you. Judge Marisa Gates and Kati Mosley.
This is Kati. I'm here.
Judge Gates is excused.
Okay. Emily Cooper and Dan Toma.
Off camera eating salad.
Thank you.
Dan is here.
Thank you. Cindy Cecil and Ebony Clark.
Ebony will be joining us shortly, and Cindy is traveling today.
Okay. Carissa Cousins and Michael Berry.
I am here.
Carissa's here.
Thank you. Jill Archer and April Flint Gerner.
April's here. Jill's on sabbatical.
Dana Hiddle and Andrew Grover. Okay. And then Alicia Overstreet and Adam Rodakowski.
I'm here.
And I am here as well.
Great, thank you. And I'm Annette Magicotomy, family member representing juvenile legal systems. Glad to be here. And we're going to welcome our newest member, Zafir Michael Berry. She's the youth representative to the SOCAC. I'll have her introduce herself and tell us more about what brings her to the SOCAC.
Hi, everybody. My name's Zafir Michael Berry. You've probably seen me around before because I'm a little weird and I like to argue about hamburgers and tacos. I use he, they pronouns. I think I'm officially the youngest member on the SOCAC, and I'm one of the founding members of the UK council. Doing that for the last couple of years. So yeah, very excited to be here and to be amongst all you really cool people. If anyone, for any reason, I don't know if we can do this, but I'm going to say it anyway, feels the need to say something but is too worried about saying it themselves, you can always message me and I'll do it for you because I got a loud mouth and I like to use it. All right, let's have a great meeting, y'all.
Thank you, Michael. Appreciate you. Okay, I'm going to go through our group agreements. Family and youth are welcome to participate in the meeting at any time. Members of the public who are not youth or family members can speak during the public comment period and freely contribute to the chat. You can send a private chat message to Jarlene Carter, Alicia Overstreet, Annette Magicotami, and Michael Berry if you have a comment you want someone to say for you. Our group agreements are be present and participate. Varied and opposing ideas are welcome. Challenge ideas, not people. Focus on our purpose for improving the system of care of Oregon. Practice respect, avoid interrupting, and use the pronouns that people introduce themselves with. Honor those with quieter voices, lean back or lean in. Be mindful of the power dynamics in the room. Avoid acronyms. Use the chat to write definitions or ask for clarification. Avoid problem solving for individual situations or crises. And propose solutions. Adam?
Thanks, Annette. Yeah. And before we move on, I do just want to address one of those group agreements. I'll get to the gear here. But I want to stress the varied and opposing ideas are welcome and to challenge ideas and not people. And so I just want to make that very clear that that is our group agreement, and we expect to follow those group agreements. If you or your organization are unable or uninterested in following those, I would encourage you to consider, about your presence on this council and if you can hold those group agreements or not. On that note, there's been some discussion and some things going back and forth recently that I just want to take a moment to address. An email was sent out to the council regarding some proposed amendments to our SOC omnibus bill. And it included language that was in partnership with DRO, Disability Rights Oregon. And so I just want to make it clear that Disability Rights Oregon responded and did not feel that accurately reflected their opinion and positions. And so I want to make clear that DRO, Disability Rights Oregon, does not support those proposed amendments, and that they believe they were proposed by DHS. And while there were meetings held, DRO was not in agreement with them. So just want to put that on the record. I'll make it clear also that if any members of the council have concerns about Anna and the way that she is representing us, you can come to Annette and myself. We're the co-chairs of this council. We'll address that. Anna, while she receives a paycheck from the Oregon Health Authority and as a government employee, technically, she does not answer to anyone at DHS or OHA. She is a representative of the 25 of us who are council members and is asked to do the will of the council in her day-to-day work. So if there are issues with that, those need to come to the co-chairs of the council to be addressed, right? And so I just want to make that very clear. Like, Anna is very open and transparent. She is trying to do everything that she can to improve the system for children and families in Oregon as our representative. So if there are concerns about that, feel free to let Annette and I know. Okay, we can move on to the narrative. So we have all agreed to use the GARE tool on this council. Government accountability and for racial equity tool. Um, it requires us to ask the following questions every time we make a decision on policy, program, or budget. Those questions are there. What are the racial equity impacts of this decision? Who will benefit from or be burdened by this decision? Are there strategies to mitigate any unintended consequences? And is completion of the full racial equity worksheet warranted? So we worked through GARE analysis of both our legislative concepts at their January and February meetings in the System of Care Diversity, Equity, Inclusion Committee. And again, we'll be talking about that analysis of the SOC ACE, the System of Care Advisory Council Omnibus Bill later on today. So with that, we're going to move on to Annette, who's got some kind of a grounding discussion for us. So I'll turn it over to you, Annette.
Thank you. I just want to say that it is just really been a pleasure. That intro was really great. Is cereal a soup? Or yeah, is it a soup or a cereal? I mean, that's great. We have so many opposing views and opposing ideas. I grew up on cream of wheat and cornmeal mush and all that stuff. So for me, it's a cereal. There was nothing special about cream of wheat or any of that. But I just say that to center us that there's opposing views, there's thoughts that I may have around the juvenile legal system that other folks don't have, and that's just one thing. There's all kinds of different and varying opinions, and I love what's in our grounding to attack the idea, not the person. That's very, very important. And I think what I learned from just the intro today was that just how different things are for many, many people and how different things are for many of the families we support. I support kids who are going through juvenile justice, who've been through juvenile justice. Maybe their parents have been through it. And each experience has been different for each one of those people that I work with in the community. And I'm sure as it is for all you all who are boots on the ground, working with kids and families. So I just want to center us that everything is going to be different for everybody. And so I know I'm just calling on some personal experience. When I first met Alicia, I was like, oh no, you don't know nothing about about what it is to be in an urban area and work with Black folks because you don't have any out there. First thing I saw when I went to visit, Jolene and I went to visit Alicia, was a Black man running down the street with his dog. And I thought, she's right. We are represented out there. And I appreciate her for having that perspective. So I say all that to say that, and Alicia and I and Jolene have gotten to know each other. One person who's not on the council anymore was Bill Bushka. And when I met him, when we had an in-person meeting, I think it was in Salem, maybe, and, it was just so nice. I really look forward to April because it was so nice to actually see someone from behind the pain here and get to know them and get to hear his story, get to hear how he came to be in the position he was in. And I really appreciated him for the knowledge that he shared. And every one of us comes with knowledge about the systems that we work in and cross systems as well. And so I just want to center us and encourage us to be open-minded, hear everyone out. One of the things is attack the problem, not the person. So I want us to do that and really feel comfortable in this space to really tackle what's best for these kids. What's best? I've seen kids go try to get help. I've seen kids not get help and go further down the pipeline with all different types of conditions that they should have been helped early on. We're trying to help kids early on so that they don't go down a pipeline as well. So I just plead to each and every one of you to just let's all work together and let's center what's best for kids and families and support them for what they're going through right now. For some kids, that sailed, and for many more, we have a duty to interrupt the system. So I just plead to each and every one of you, let's relax, move your shoulders, shake it off, because we're here to do the best we can for the kids in Oregon. And I plead to you to let's just focus on that and work together. Thank you.
Thanks, Annette. Yeah. Assuming positive intent. Absolutely. Right. Like we're all coming to this work with a shared purpose. All right. We're rolling into subcommittee reports. First up, we have our wonderful crew from, the Oregon Youth Addiction Alliance. Do we have Caleb or Cameron? I see Cameron. Hey, Cameron.
Yeah. Hi. Dang it, we thought we were gonna be on in about 20 minutes, so I don't think Caleb's here yet. But
Do you want me to wait and come back to you?
yeah, that'd be great. I'll text
Cool.
Caleb to try and get on as quick as he can. Thank you.
Yeah, of course, no worries. We're flexible to move on the fly here. So, how about Family Advisory Committee? I don't think you guys have a cool acronym like but not yet anyway. But Alicia or Annette, which one of the two of you want to lead this one?
Guess that's gonna be me. What did we do? So far, I think we've had a training. I think Joylene could probably elaborate more on that one. And we had a meeting where we actually talked about the difference between, or what SOCAC is, what system of care is, and all those different things that we on the council we talk about on a regular basis. But I really wanted to, or Annette and I really wanted to make sure that family members and caregivers who come into this work with the council have a good foundation and some of the words and the programs and what they all mean. And so we did that. It was a really fruitful conversation with lots of questions, and I invite any and all family members and parents and caregivers to join us at our next meeting, which is going to be tomorrow afternoon. And that we'll probably start working on or actually the group agreements. Sorry. So yeah, that's pretty much it, unless Annette or Joylene want to add something to it.
Nope, you said it all.
Yeah, I just want to share that the policy advocacy trainings Alicia was referring to, we had 3 of them, all for family reps, hosted by Common Thread Consulting, SOCAC's family engagement contractor. So they have been, the last one actually ended yesterday, and we're actually going to have another one for family members and opening it up to community members in general. Youth are welcome, all folks with lived experience who are interested in learning more about how to do advocacy and turn their lived experience into strong advocacy stories. That is going to be next week, Monday, March 10, from 3:30 to 5:30, and the information is on SOCAC's website. So just adding that. Thank you, Alicia. Great job.
Question. Oh, Emily, you quick on the hand. Okay, go for it.
Yeah, I mean, if y'all are interested in learning more, Disability Rights Oregon this year for the first time joined a national group called Partners in Policy Making. And the whole thing is it's a year-long intensive for people with lived experience, but they've extended it to families and allies. So our first cohort is graduating this summer. I'll put more information in the chat, but we do this intentionally so that people with lived experience can master the tough gauntlet that is navigating public policy. And so if anyone has any questions about our program, please let me know. It's really cool.
I just had a question about recruitment. Like, how's recruitment for the seats on that subcommittee going?
It is so great. It's like I planted you, Adam. I think our first year was tricky because it was really just word of mouth. So it was people we knew and we relationships. So there was a level of I don't know, good old boy is probably not the right acronym, but like people we knew. But part of why I want to uplift this program to you all is I'd love it if you took it out and we had more diversity in terms of applicants. This year, almost everyone wanted to focus on special education policy, which is needed. But I think it shows, some of our work in the special education space versus we know housing's really important. Having culturally competent providers is important. So we'll keep it going, but it's an application process and any and all are welcome.
What about our crew? Oh yeah, Joylene, what about it?
Yeah. So, or Alicia or Annette, did you want to take this question?
Is it the same question that Emily got?
Yes.
Okay. Yeah. So that's one of the things where right now it's more of a whoever's interested, can show up and we'll go from there. And I think that's one of the things that we're actually working on together as a group is figuring out things like group agreements, as well as how do we want to get family voice to the table. We were wanting to do something a little bit more fluid, but moving up against bureaucracy, we're gonna have to rethink that a little bit. But I think right now if you're interested, reach out to either myself, Annette, or Joylene, and then we'll go from there. And yeah, but there's nothing that we have like set in stone as of yet in terms of recruitment policy or process.
Cool. That's good. Good to know. But yeah, like trying to get grounded before you get too far out ahead of it. Yeah, okay. As I'm sure, and it'll be great, or at least, it could be a great opportunity for folks from locals to be involved on the state side too, as we continue to kind of look at the structure of councils within Oregon, to yeah, help make sure we're moving that voice from the local to the state level. So that's cool. Right on. Youth Council. Jesus or Zafir? I don't think Jesus is here, is she?
No, so Jesus is not available today. I'm happy to give this update on Youth Council. Before I do that, I want to check in with the youth in the room. Are any of you interested in giving a Youth Council update?
I would prefer if you did the update just because I am not prepared to report out this month.
Yeah, no problem. So the SOCAC Youth Council has been continuing to have regular meetings every other week, plus a fun in-person outing at the Portland Winter Lights Festival. Thank you so much to the youth engagement contractors at the Oregon School-Based Health Alliance. Fatih and Maureen, I see you in this meeting today. They were very, very helpful in getting youth from across the state to actually all be together in person and helping sponsor travel and lodging for that in-person meeting. So we are very, very grateful. Youth Council is still focused on their typical priorities on top of preparing together to do a panel presentation in Salishan at the Alliance conference. So if you are a provider and you're planning to be at that conference, expect a really fun presentation with a panel from the System of Care Advisory Council, Youth Council. I believe that is it. One more thing that just crossed my mind is they are working together in partnership with Bobby and Maureen from the Oregon School-Based Health Alliance to give us some good data on how we can be doing youth engagement better, the things we are doing good and what we need to improve on. So that all is going to come together, I believe March 21st. There's going to be a big in-person meeting where they actually draft a youth engagement plan for SOCAC internally, as well as the system of care overall. So keep an eye out for all of that, but those are top priorities Youth Council's working on. Thank you.
Thank you, Jolene. Any questions for Jolene? Seeing none. Are there other council subcommittee chairs who want to provide a quick report? Not to put anybody on the spot. Cam, are you ready? I was trying to buy some time for you, but if you're ready, Cameron,
Yeah,
go.
I don't think Caleb's gonna make it today, unfortunately, but just a quick update from us, the Oregon Youth Addiction Alliance, or OYA, but we've started work on topics that are going to go into our strategic plan. We just last month had our first work group meeting, and it was really successful. We're looking forward to continuing the work at our meetings this month. We have 2 meetings every month, and our work group meeting is actually being moved to the second Thursday, Thursday of this month instead of Wednesday, because next Wednesday a lot of us will be going down to Salem for the legislative hearing for a bill that supports OYA's work. So if you're interested in learning more about that, please reach out to Joylene and I, and we will give you more information. But yeah, we're really excited about that, and we have some partners that are trying to pack the house with youth, so that should be really exciting.
You any questions for Cameron? Emily, go ahead.
Yeah, there's a lot of bills happening. I'd be curious to know like which ones y'all are prioritizing to pack the house and mobilize on.
Yeah, specifically this one, Darlene might know the number. I can't remember it off the top of my head. I'm trying to pull up. I have a lot of bills open in my tabs right now, but it is, hold on, I'm so sorry. Give me just a
It's going to
second.
be House Bill 2502 is
You
the
mean-
one that they're going to testify on. And then the second one that we're following and supporting is 2507. This one was originally an idea from Caleb Gamby, the other youth chair. Yeah, both of those bills.
Yeah, so the one that will be packing the house for also includes 2502, also includes some stuff about funding recovery schools and just really supporting the work that OYA is doing in this strategic plan. So encourage you guys to look it up, and would love to answer more questions if you have any.
Thank you. Other questions for Cameron? All right. I think the last thing on this agenda item is that council staff have an announcement about public meeting law trainings for subcommittee chairs and members. So everybody perk up. I think Corinna, are you giving us the heads up about this?
Hi there. Sorry. Yeah, let me pull that information real quick. I did send it out to all the on the exec meeting notes. So if we could ask the chairs to help distribute that information. But there is going to be public meeting law webinars coming up, and there's several times that they have that you can sign up for individual training. And this just kind of helps, if you haven't taken this, understand what, as a council member, your responsibilities are, and what the public meeting laws are. So it is a training, I believe it's about 150 minutes. And there's several sessions in March, and there's several sessions in April. Later in the year, we will be looking to do a specific invite for them to come present to SOCAC. So that will be a little bit more aligned for us and questions there, but it'd be great to get people in some trainings and kind of get an idea of what's going on in that space.
Thank you. And I think this is important because we want to make sure we're not violating any public meeting laws. And there have been a couple of things brought to me as one of the co-chairs over the last couple months where folks have been expressing concern about that. And so, like, I just want to stress for our council members, all of our subcommittee chairs and the members of those that, like, whether you are familiar with the law and requirements or not does not matter. You are still bound by them. So educate yourself. Make sure that you are following public meeting law when you are having discussions with council members and subcommittee members. So with that, I think I can turn it over to Annette.
Thank you, Adam. System of care assessment. So I'm going to introduce Dr. Becky Marshall and Amanda Rivers, research manager and MPH director at OHU Data Evaluation and Technical Assistance Team. They'll go ahead and walk us through the assessment. Thank you so much. Go ahead.
Thanks. Can I take over sharing so I can share our slides?
Yes, who said that? I'm sorry.
It's Amanda.
Got you. I will make you a co-presenter.
Okay, thank you.
Welcome. Amanda, when it works, you'll see that green share button in the bottom center of your screen pop up. Has that shown up for you yet?
Yes, let me. Okay, you guys can see the slides?
Yep.
Great. All right, Becky's going to kick us off.
Okay. Hi, everyone. It's nice to be here. We are really excited to do this presentation. We've been working on this report for a long time. So I'm Becky Marshall, as Annette said. I'm the director of the Data Evaluation and Technical Assistance Team, or DATA team, which I realize is a mouthful. And I'm going to be starting off this presentation today, which is about the data report that we prepared on the Oregon System of Care. So just to start out with some team introductions, the data team has contracted with OHA since 2017 on several statewide behavioral health programs for youth and families and adults. Our work really involves collaborating with OHA and with community partners to collect data, to evaluate the data we collect, and then to feed it back to our community partners and OHA. And this allows us to show what's happening on the ground with behavioral health programs and with the youth and families that they're serving, so that we can see where improvements are needed. What I want to say about our team before I get started is that everyone on our team has a background either in behavioral health care or has lived experience. So to be honest, we're not that excited about data for its own sake, but we're really focused on data as a tool for meaningful improvements. So when Christy Hudson approached us over a year ago to ask if we could help with this data project, we were really excited about the potential for kind of helping improve the system. Our data team has actually become a pretty big team, so I'm just going to introduce the team members here who contributed the most to this report. Like I said, I'm Becky Marshall. I'm a child psychiatrist, and in addition to directing the data team, I'm the director of pediatric emergency psychiatry at OHSU, where I do clinical work with youth and families in crisis. Julie Majors is a family support specialist. Her current role is to bring the family voice to all of the data team's work. Amanda Rivers is our team manager who provides support to all of our projects. And Masuma Musavi is the SOCAC project lead. And I just want to say that I'm really grateful to the whole data team, many of whom are here today to support us, for all of the ways that you support our team and supported this project. You're really amazing individuals and coworkers. Okay, a few acknowledgements. Our SOCAC partners contributed a huge amount to this report. And we especially want to thank Christy, Cody, and the data subcommittee. It was an honor to work with you all. We also want to thank the huge number of other individuals who helped with various parts of this report. I'm quite confident that we left someone out, so I apologize if we did. So today's presentation is going to be a joint presentation. I'll start out by giving an overview of the project, our process, and the strengths, limitations, and implications of the work we did. Amanda is then going to take over, and she'll talk more specifically about the data that's presented in this report. We do expect that there will be a lot of questions that come up for all of you throughout this presentation. So if you have questions or comments, please go ahead and put them in the chat. Our team will respond to what we can, and we'll also leave some time at the end for questions or thoughts. Okay, so jumping right in, I'm going to talk for a few minutes about the timeline and process of this project, because it's really important both to understand some of the limitations of this report and to understand some of the clear lessons that we're hoping will come out of it. So my team started this project in January of 2024. We call this first few months of our work phase one, which was really about identifying the questions that we were going to be asking in the report. And that actually took quite a while. So we started working with Christy and the data subcommittee to develop the framework for this report. And we started with 6 overarching questions, which are in this blue box here. Who is being served by the system of care and who is not? What is working and what is not? And finally, how much money is being invested into the system of care and where is it being allocated? So we took these big questions and broke them down into many smaller questions. I think at last count, it was 76. And then we organized them into categories so that we could kind of make sense out of them. And what I really want everyone to know is that this was a very collaborative process. We worked with the data committee, with the SOCAC Youth Council, with agency partners, and with individuals with lived experience. And we got feedback in many different ways, ending up with a highly honed set of questions to really get at the important issues around how the Oregon system of care is functioning. So we finalized our questions, and then in around May, June, we were able to start trying to get some data use agreements. And what we learned is that the processes for getting these agreements in place are very complicated to navigate and may take months and months. In some cases, it took us 8 months. So the second phase of the project was gathering data and then seeing where we needed to fill in gaps with more data. Most of the data for this report, the majority of data for the report, was from system of care agencies. So we needed to get data use agreements in order to get this data. But as I said, there were really long delays in getting these data use agreements submitted and approved. So we didn't actually get a lot of the data in this report until really late in the year, like December or January. And I've noted in this slide some of the specific difficulties that we encountered in getting data from system partners. So in August, we started to get some agency data. And as we started filling in answers to questions, we were able to see where there were gaps and where we needed to go out and look for other data sources so that we could answer some of these questions that we were tasked with. And I'll talk about that a little bit more in a couple of slides. As we were filling in the report, we realized together with Christy and Cody that we really needed more parent and caregiver feedback. This was not part of our original work plan, but we felt like it was important. And so we developed a survey for families and caregivers while we were writing the first draft of the report. And I'm just going to show you a little bit about this. So we developed this family and caregiver survey together with SOCAC's qualitative work group, which was made up of people with lived experience. We sent it out and got 108 completed responses from people representing different parts of the system. And then we conducted 25 in-depth follow-up interviews. So we were able to really get at some details about parent and caregiver experiences. And we got some really rich feedback, which we've included throughout the report. Okay, so back to the timeline. In this last phase of the report process, we focused on getting a draft written, and then we got a lot of reviews. And just to be explicit, we got reviews from subject matter experts, from SOCAC representatives, from agency representatives, individuals with lived experience, etc. A lot of data sources that had not initially been identified were able to come out of these reviews that occurred in December and January. So again, pretty late, but we were able to pull more data. We were able to revise the manuscript several times. And by the end of this year-long process, we were able to answer a lot of really important questions, though not all of them, as I'm going to talk about in a minute. So these are some of the data sources that we used. In total, we used data from over 450 sources, which are cataloged in the annotated bibliography at the end of the report, which I think is like 60 pages. It's very long. We used multiple data, qualitative, quantitative family youth surveys, literature reviews. And the goal was really to get a number of perspectives from multiple angles on the system of care. Okay, so I'm going to transition here and talk for just a few minutes about the strengths and limitations of the process of developing this report, and then some of the lessons we learned. And we're doing this first because I really want people to listen to what we have to say about the lessons that we learned. I think it's really important to come away with some of that feedback. So first, strengths of the process. There were a lot of strength in the process that I just described. Collaboration with SOCAC was fantastic. We obtained perspectives from many individuals with a range of different backgrounds and experiences. We worked with some pretty awesome agency and non-agency collaborators throughout the system of care who answered questions for us at a moment's notice, sometimes stayed late and worked on weekends to fulfill our data requests. There was a lot of effort and a lot of commitment to helping us complete this project. And there's a lot of data that exists about the system of care. It's not always easy to access, but it's there. And then finally, there's really strong interest within the system of care for using data to drive system improvement. So I think we have the data, we have the interest and the drive. It's just a matter of figuring out some systems that will help us get there better. That leads me to kind of the limitations that I want to talk about. There were some really important issues that limited what we were able to do with this report. To start off, a year was not enough time for a project of this scope. I talked about this a little bit earlier. It took a long time for our team to identify where we could find system data, who to contact, to actually get data agreements approved, and then for agencies to do the data pulls that we asked for. These teams and systems are really understaffed for the important work they're asked to do, and that was clear. In addition, some data is not available within short time frames. For example, some insurance-based data at OHA can't really be obtained in less than a full year. Okay, limitation number 2, data silos. So our experience doing this project really illustrated that our SOCAC data systems function in silos, and they are not operationalized to work together. The silos are not coordinated, and they don't have standardized processes in place to be able to easily coordinate efforts and share data. As a result, it's extremely difficult to accurately track cross-system data, such as who is involved in multiple systems and issues like access and outcomes. So here's an example of that and why it's important. What are the long-term outcomes for youth in the juvenile justice system who have intellectual and developmental disabilities who access behavioral health treatment? And then in comparison, what are the long-term outcomes of youth in the juvenile justice system with intellectual and developmental disabilities who need behavioral health treatment but can't access it? Those are really important questions, and it's very hard to get answers to them because of the way our data systems are currently structured. Okay, third issue, data sharing and access. As I mentioned earlier, trying to get access to data in different systems, even de-identified data, even for a project for the state system of care, ended up being really difficult and inefficient. Even with a lot of guidance from Christy and other SOCAC members, it was hard to figure out who to talk to, what data was available, who managed it, and how to get permission to access it. Even within individual agencies, it seemed like staff didn't always have shared knowledge of what data the agency tracked and what the process was to obtain it. And fourth, data consistency. So for a functional system where data can be shared and connected across different agencies, there needs to be some consistency and standardization so that there are core data elements that are collected across systems using the same definitions and the same parameters. A simple example of this is age. When one group defines youth only as 0 to 17 years old, and another defines youth only as 0 to 25 years old, it makes it difficult to compare the two groups. And our team found while we were defining youth as 0 to 25, a lot of national data defines youth as 0 to 17. So we weren't always able to compare groups. And finally, insurance and financial data. This report mainly focused on data for publicly insured youth. It did not include physical and behavioral health data for youth with private insurance, military insurance, or no insurance, and that's because of the length of time that it would have taken to have gotten that data. We also didn't have time to get detailed CCO expenditures and outcomes or behavioral health care in the medical home. And there's a lot of complexity to financial data that we really only scratched the surface of. So I think that's a really important piece that needs to be followed up in future reports. Okay, so this is my last slide, and then I'm going to hand it over to Amanda. I just want to recap some points. So for this project, we were asked to take data from each part of the system of care and put it together to answer really important questions about where the system is working, where it's not working, and what needs to be improved. These questions and the answers really matter for youth and families. We all know that. And we were able to get answers to some really important questions, which Amanda is going to talk about in a minute. However, we were not able to get at some of the answers to really important questions. And as I've been sharing, our experience of navigating data systems in the system of care was too difficult. We learned that data systems are siloed, fragmented, and disconnected in ways that really reflect a lot of the things we heard about the system of care itself. So kind of like parallel processes. So first of all, we recommend that there be further efforts to answer many of the unasked or unanswered questions. And to allow this to happen, resources really need to be invested in developing some centralized planning and coordination of data systems so that really important metrics can be connected across systems. And I just want to conclude by saying that the work we did over the past year highlighted a really incredible community of individuals. There are a lot of ways that the system of care needs to be improved, but there's also a lot to build on. We have a lot of evidence of pretty amazing investments that are being made both by individuals in the work they do every day and by institutions and systems. And we really can't lose sight of those investments. They're really important. And we have to work together to build on them. So we hope that this report can help with that and can be kind of a solid platform to continue to build on. Okay, I am going to hand this over to Amanda, who's going to actually describe more about the data in the report. Thanks, everyone.
Thanks, Becky. So now we're going to talk about the specifics of the data report. First, I'm just going to give a brief overview of how the report is organized for people that may not have had a chance to read it yet. This is especially important because after that, I'm going to present just a few big key takeaways from the report. Because of the limited time we have today, I'll really just be scratching the surface of all the important findings. So I'm going to start by breaking down the table of contents to explain how we organize the report. First, the executive summary contains some of the major takeaways from the report, and those findings are what I'm going to focus on today. The introduction provides an overview of what the system of care is and explains the methods and limitations of the report, some of which Becky mentioned earlier in the presentation. Next, there are two chapters, population description and neighborhood and community. These chapters provide important context for the population that we're describing in the report. And after that, there are 6 chapters that focus on the individual systems: education, physical health, behavioral health, IDD, child welfare, and juvenile justice. Next, there are 4 chapters that pertain to the system as a whole. So we talk about system workforce and funding, the youth and family experience of the system, and the system's readiness for transformation. And finally, the report closes out with a conclusion that includes recommendations for future data-related efforts. There are 2 appendices. The first is a county crosstab that enables comparison across different regional groupings in the state. And the second is a list of the 76 research questions with comments on any missing information. At the end, as Becky mentioned, is a very long annotated bibliography which lists all 450 sources used and provides a brief description about each source. As you move through the report, you'll see that each chapter starts with an introduction and key takeaways from the chapter, which is helpful if you just want a high-level overview of the information. And then the chapters are organized in a Q&A format with the research questions presented in blue boxes and then the narrative answer provided below. There are tables, graphs, charts, quotes, and all throughout the report. As mentioned previously, there are 6 overarching questions that guided the work and the development of the 76 research questions. Today, we're going to frame our discussion around these 6 questions, starting with questions about who is accessing the system of care. Okay, so this table shows the annual volume of youth served by each system. The education system, unsurprisingly, serves the highest volume of youth. Next, the behavioral health system serves around 80,000 youth per year. The IDD system serves around 15 to 20,000. Child welfare and juvenile justice don't have the same temporal trends, but in 2023, child welfare served around 10,000 and juvenile justice served around 7,000. Next, we're going to look at the demographics of youth served in the system of care compared to the general US and Oregon population of youth under 25. First, we're going to look at age and sex. The Oregon Department of Education serves a population that's pretty consistent with the state general population, so I'm going to focus on the other 4 systems. First, as you can see in the highlighted boxes, behavioral health serves more older youth and female youth. IDD similarly serves older youth, but with a higher proportion of males than females. Child welfare differs from the other systems in that it serves more younger youth, and the sex distribution is consistent with the state population. And juvenile justice serves youth mostly ages 15 to 19, and over 2/3 are male. I'll give everyone a second to look at this one. Okay. If we look at race and ethnicity, American Indian and Alaska Native youth are overrepresented throughout the system of care. So this means that the proportion of these youth is greater in the system than the population observed in the state population, or the proportion in the state population. So, for example, American Indian and Alaska Native youth make up 1.2% of the population in Oregon, but they represent 4.2% of the population served by behavioral health. This is also true for Black and African American children. And white youth are overrepresented in the behavioral health and the IDD systems. As we go through the data portion, I just want to remind people you can put questions in the chat, and we'll come back to those in a bit. Okay, when we look at clinical presentations of youth in Oregon, we have some of the highest rates in the country for depression, substance use, trauma, which includes adverse childhood events or ACEs, and suicidality and suicide deaths. It's important to acknowledge that the Oregon system of care is supporting youth with really complex, serious needs. And so now that we have a sense of the population being served, let's talk about what's working well in the system. And again, this is really just a sampling from the report. First, one research question asked about educational and support services for families, and there are a number of these. A variety of organizations offer resources to help parents and caregivers learn about diagnoses, conditions, behaviors, and services that may be helpful to them. There are also educational and support services available specifically for youth. And of course, youth are the focus of most of the services in the system of care. Next, school-based health centers are an important resource for Oregon youth. There are 87 school-based health centers in 28 counties across the state. Youth can obtain medical care, behavioral health services, and often dental services. And these centers really reduce barriers that may prevent parents and students from seeking health services. The counties in Oregon that lack school-based health centers, which are primarily located in rural areas, often offer mental health services to schools through direct funding from the Oregon Health Authority. As you can see in the table, over 6,000 youth received behavioral health visits through school-based health centers, with the exception of 2020 to 2021 during the stay-at-home orders. Next, there have been significant efforts towards statewide suicide prevention in recent years. We know that rates are really still high in Oregon, and it's difficult to come to many positive conclusions when looking at this graph. And while progress still needs to be made, we do want to note that things are trending in the right direction. The Big River program is a statewide initiative sponsored by the Oregon Health Authority that launched in 2019 after Oregon peaked in the number of youth suicide deaths in 2018. The program has a number of trainings available to the community, allied professions, and mental health providers. The number of people trained in these programs has increased at a really impressive rate, with almost 10,000 people being trained in 2024 alone. And since its peak in 2018, the overall rate of youth who die by suicide in Oregon has decreased, although not back to numbers observed prior to 2018. It is important to note, though, that the majority of this decrease has been among white youth, with either no change or slight increases among Hispanic youth, American Indian or Alaska Native youth, Asian youth, and Black youth. Another important effort to support youth experiencing mental health crises is a recent investment in community-based crisis programs. The Oregon Health Authority has recently invested significant energy and resources into bolstering the statewide crisis continuum. 988, the Federal Suicide and Mental Health Lifeline, which is staffed by Lions for Life and Northwest Human Services in Oregon, was launched in July 2022. Around the same time, the rules and practice guidelines for mobile crisis were updated to improve standardization both within the state and to national best practice models. Finally, stabilization services was launched and, similarly to mobile crisis, implemented in a standardized way across the state to improve access to this service. MRSS is an 8-week extension of mobile crisis that's only available to youth. After an initial crisis encounter, youth and their families can receive care coordination, short-term mental health treatment, and peer support. These programs are still in their early stages of implementation, especially MRSS, and they have been faced with workforce shortages and staffing challenges. Once programs are fully operational, they have the potential to greatly improve access to needed crisis support. And finally, another innovative project that's been going on is that Child Welfare is piloting 2 initiatives centered around individualized care and immediate response: the Response Support Network and Child-Specific Caregiver Supports. RSN provides immediate response and individualized supports to resource parents and post-adoptive parents to help address challenges and connect them to longer-term resources. The program is currently available in the Tri-County area. The CSCS program is currently available in 8 counties and provides in-home and community-based care tailored to youth-specific needs. Both programs are aimed at improving placement stability in the least restrictive level of care possible, and ODHS is currently advocating for statewide expansion. As Becky mentioned when we started this presentation, one thing is super clear: the state of Oregon, the individuals who work in the system, and the youth and families who have experienced the good and bad of the system are all dedicating so much time, effort, and money into improving the system. As I outlined in some of the last few slides, a lot of innovative and positive things are happening, with many new initiatives in the early stages of implementation. Systems improvement takes time and requires both support for new developments and reflection on things that need to be improved. So on that note, we're going to also identify areas that are not currently working well in the system, and I'll jump into those now. First, Oregon has over 1,400 unaccompanied youth experiencing homelessness. Of these youth, 70% are unsheltered, meaning that they spend the night in non-designated sleeping accommodations like parks or sidewalks. This rate of unsheltered youth is the highest observed in the country. We are also ranked as the highest in the country for the number of unsheltered families with children. Turning to education, Oregon has higher rates of chronic absenteeism than the national average. Additionally, we have some of the lowest graduation rates. Graduation rates are especially low for youth who are likely to be cross-system involved, including students who are in foster care, experiencing poverty, students with disabilities or are learning English, students who are experiencing homelessness, and those who are Asian or American Indian and Alaska Native. Moving on to child welfare, as you can see here, Oregon has high rates of child abuse and neglect referrals and higher rates of found maltreatment than US national averages. Entries to foster care are similar. That's in the table. Additionally, the rate of maltreatment while in foster care is substantially higher in Oregon than the federal threshold, which is shown in the pink and black graph. It's important to note here that Oregon has one of the lowest thresholds for substantiating abuse and neglect in the country, which may account for some of the differences observed here. And as many people know, Oregon ranks poorly on several measures of youth mental health indicators. The map on the left is from Mental Health America, and it shows a combined ranking of youth mental health prevalence and access to care. Oregon is ranked 49th out of 51, indicating that we have high rates of youth mental illness and poor access to care. On the right, the Kaiser Family Foundation used data from the National Survey of Children's Health to estimate what % of youth face difficulties in obtaining mental health care. Oregon's rate is 73% versus the national rate of 57%. The parent caregiver survey we conducted provided additional evidence about barriers to accessing care. While our sample size was limited to around 100 individuals, these were not unique results and themes that we haven't heard in other focus groups and surveys. First, in the education, behavioral health, and IDD systems, only around 1/3 of parents feel that their youth have received the help they needed from the system. Physical health and child welfare are higher, around 2/3. Parents report that a number of barriers impact their ability to get their children the care that they need, including a lack of transparency around program and service eligibility, unclear pathways into care, inadequate coverage for certain services specifically for complex or high needs youth, poor communication within and across systems, and an overall concern that parents must be knowledgeable and savvy to successfully navigate the system. In the youth survey that SOCAC conducted separately, several similar barriers emerged, including finding services unhelpful, lengthy wait times, difficulties obtaining a diagnosis, complex needs or symptoms interfering with their ability to get proper care, prohibitive costs, issues with physical access, parent-guardian support, and experiences with discrimination. And finally, related to some of the barriers that parents and youth report, many individuals who work in the system know that we are facing widespread workforce shortages that are impacting system performance, especially in the behavioral health workforce. This map shows the number of behavioral health providers per 10,000 people in the population by county. And some counties are facing exceptional shortages, like Wheeler and Sherman counties. Again, this is a lot of information to take in. I'll give you guys a moment before I move on to the next topic of funding. Okay, so the last set of questions that were in the report, how much money is being invested into the system and where is it being allocated? And these are very big questions themselves that could probably be their own 200-page report. So this is very high-level information that we're going to be providing today, and there's a lot more in our report. For our purposes, we took a high-level look at system funding using legislatively adopted budgets, or LABs. These are budgets given to agencies after the process outlined in the figure on the slide. While these budgets are helpful for understanding how much each agency receives from the state general fund, federal government, and other special dollars like lottery funds, they only tell part of the story. These are the funds that the state agencies receive. They don't account for initiatives and programs funded by specific counties or regions, commercial payers, or private foundations and institutions. For that reason, we suggest that readers interpret the financial chapter with caution, as more in-depth analysis by financial experts is needed to fully understand the flow of funds and how that impacts the youth system of care. So today, I'm only going to present the total allocated budget for each of the major system partners, which is shown in this graph. As you see here in green, right here, the Oregon Department of Education received around $16 billion for the current 2-year cycle, which is called a biennium. So we're looking at 2023 to 2025. Next, the Oregon Health Authority in blue. They have the largest budget of almost $36 billion, but it's important to note that this represents the lifespan and all of their programs. So physical health, public health, behavioral health, etc. So we asked OHA how much this budget is allocated specifically to youth mental health, and they reported about $6 billion is allocated to that for this current biennium. So that's this dark blue box down here. The Office of Developmental Disability Services, which is in yellow, is similar in that they serve the lifespan. So we again asked them to provide an estimate of how much is dedicated to youth, and they reported $2.5 billion for the current biennium, which is about half of their budget. Next, we have child welfare. Their current budget this year is $1.6 billion, and Oregon Youth Authority is a little less than $500 million. So in the report, there's additional data for each agency. So we go over what proportion of each of these budgets comes from the different sources. So what percent of ODE's funding is federal versus state, special funds like lottery funds. And we also outline where each agency is spending their money. So what percent of their budget is going towards program delivery versus administration, etc. We just did not have time in today's time frame to be able to include all that information by agency. Finally, the report compares Oregon investments to other states. But again, it was really difficult to compare because a lot of our systems serve 0 to 25 or 0 to 26. And a lot of the states that we're comparing to was 0 to 17. So it's really hard to compare budgets with that different age definition. To wrap up, I'm going to just present some of the conclusions and recommendations that we came to while completing this project. While we weren't tasked with making recommendations to improve the actual system of care, that's SOCAC's job with your strategic plan, we do have a few recommendations pertaining to data. Today's presentation just included a very small sampling of the many questions asked in the report. You'll get a lot more information as you read through the final report. There are still many unasked and unanswered questions, and in order to answer them, we need to change how we think about data in the state. SOCAC should aim for improved data systems and coordinated statewide data management. Specifically, we recommend that SOCAC engage in a strategic process to examine statewide data systems and ongoing data processes to characterize areas of need and redundancy and identify a more effective statewide data strategy. We also recommend that SOCAC develop and monitor clear indicators to measure the impact and value of new investments in the system. And finally, we recommend that SOCAC work towards identifying a lead agency or state entity that can guide statewide data system of care efforts, including selecting cross-system data points, coordinating data among systems, and monitoring and oversight of key indicators. And with that, we wanted to thank you for your time and open it up to questions. I see the chat box has been pretty busy, so I think we have a good amount of time for questions.
Yeah, we do. We're ahead of schedule, Amanda. So we've got until 2:25. So if you're up for it, just dive in.
Sure. Can I stop sharing my screen? Is that all right?
Yeah, totally.
Okay. That way I can see everything.
And do you want to walk down the list in the chat, or do you want folks to raise their hands? How would you all prefer?
Julie, I think you've been keeping an eye on the chat. Are there certain ones you want us to jump to, or what strategy do you recommend?
Yeah, so I suppose we need to kind of look at what's in the chat and say there's a lot of reactions to the data that was presented. There's additional questions that were not included in the original report. Becky answered a couple of questions. So I think at this point, if people want to raise their hand to ask a specific question, recalling that the report had the constraints of the 76 odd questions that had come up, and that's what data was pulled to try and answer. There's certain to be additional questions that people are going to have.
And if I could just ask initially, like, can we get council members to raise their hands? I want to make sure if specific council members have questions, and then so we'll let Emily Cooper go first. And then if there are no other council members with their hands up after Emily's question is answered, then we can go to parents, youth, family members that have joined us as well, if that works.
So Adam, if you can facilitate that,
totally.
Be awesome. Thanks so much.
Emily, you're up.
So this is a really cool report. I think it's going to take me some time to get through it. But I think this is to understand the scope of the problem, we need to have this data. And so I think this is really, really critical. I think most of my questions are kind of in two buckets. The first is like system gap is what I'll say. So were you able to determine, say, with mobile crisis, what the demand is or what the need is for those services versus what's available? Because when I look at those suicidality rates, it's definitely concerning. And so it'd be good to know, like, where's the gap in terms of need versus what's available? And then related around a workforce, like, is there a sense of what would be needed in the system versus what's available? Those are kind of my two big questions, but then I can follow Cody's advice and actually read the report in detail and probably answer my own questions.
I think I can respond to the first part of your question. First of all, thank you, Emily, for your compliment. And I would just warn you not to try to read the whole thing in one setting, because it's like 200 pages and you will put yourself to sleep or in a coma. The question of unmet need is a really tricky one. And I don't think that we were able to really get at that with this report. With mobile crisis, for example, we don't have all of the 988 data, so we don't know how many requests for a mobile crisis response were made that were not met. And we don't have great data about whether families, for example, requested stabilization services and were not able to get them. And that's been a long-standing issue that our team has kind of wrestled with, along with OHA and with a lot of community partners, is how do we measure that unmet need? It's really important, and we don't have a great way to do it yet. In terms of the second part of your question about workforce need, if you look at the report, we actually do have some estimates of what is needed for different parts of the workforce and what we have. So you can see what that gap is in the report. Who is next?
Good, Emily? Yep. Okay. Robin is up next, and then yes, I'll open it up for youth family members. Feel free to raise your hand, jump in the queue as well, please.
We got a couple other council members with hands up, Adam.
Dan, no, I see Robin and then Dan and then Zafir, but I just figured I'd let folks queue in behind them if they want.
I'll also freely admit I haven't read your 200-page report fully yet. Have not digested it, but it's on my nighttime reading list. I'm curious, specific to areas where I know you've noted in some places that we're falling at the bottom of the barrel from a national perspective. And often that gets tagged to things related to acute care, availability of psych res, availability of some of those other types of things. And I'm wondering if you have any thoughts about that in terms of Oregon traditionally has had a culture that has shied away from those levels of care, that has not wanted to support those levels of care, because we do want to drive people back to their homes and support them in their homes as much as possible. But what did you kind of, from an overarching being very close to this, kind of glean from that information?
Glean from what information in particular, Robin?
From the, well, obviously you looked at the number of beds and the decrease in beds over the last several years. What do you see as the impact of, what kind of intel, when you look at that in aggregate, do you see is, do we, for instance, need more acute care beds? Do we need more residential beds? Do we need to focus more on other types of systems? What do you see?
I'm happy to jump in and start with this question. Robin knows, a lot of people on this meeting probably know, I work in an emergency department, so I'm definitely biased. I think it's clear that we need more acute beds, and it's clear that we need more residential beds. We're at the bottom of both in terms of national numbers. And there are some national studies that we've looked at recently that demonstrate that very clearly. I think the feedback that we got from families is that we also don't have enough non-acute care. There's not enough normal outpatient care. There's not enough intensive outpatient care. And there's not enough care for youth involved in multi-systems. I wish I could say it's just the kind of multi-system youth who kind of cross different categories who aren't getting enough care, but it's really even youth who are only in one system are having trouble connecting with the care they need.
Yeah.
Does anyone want to add to that? I think that's a really good question. No, that's okay. I just want to ask if there's anyone else who has, maybe from my team, who has anything to add to that. Okay. Dan.
Thanks. I have sort of a mixed question / comment that's for the council as much maybe as it is for the data team. But I see the value in the report itself and the data that they've gathered and the analysis that they've provided, although I admit I've only read a little bit of it. But there's also value in what the data team learned as they were going through this process of pulling these data together and pulling this analysis together. And my question is, how can we retain that value from the kind of the institutional knowledge that they've built up in pulling all of this together? And what plans might we have for revisiting a report like this in the future?
I mean, I can jump in a little bit, Dan, 'cause being the chair of the data committee. We know that we learned a lot in this process through the work of Becky, Amanda, Julie, Masuma, all of them. And like almost any project that produces information like this, we learned what we don't know and we don't have. And so we've been talking amongst the kind of executive committee. I think we brought it, I don't know if we brought it to the full council, but we are building a budget for future years for this coming biennium to build on this work, because this clearly can't be a kind of a one and done thing. We've learned a lot, but we've also identified a tremendous amount of gaps that were either unknowable or are still unknown. So my own belief is that this is going to have to be built on, and that will require time and some money and other things. And so we're working on a budget to do that. I don't know if that really answers your question, but that's what came to mind for me as you asked it.
Super helpful. Thank you.
I think another thing that's really important to consider in that question, and Andrew, how you responded, is that this report tried to answer 76 questions that were asked about the system of care, its performance, its delivery, who it's serving, all of that. And in the process of trying to answer those, additional questions came up. So be sure that while maybe a question that has arisen was not the focus of the effort to answer it within this report, those additional questions, now contextualized and stimulated by answering the questions that you all came up with initially, are going to be really important in your continuation of using this report, and then whatever your strategies and efforts are going to be moving forward. So I would urge you guys to kind of have a place to put all of those questions.
Yeah, and some of that the last thing I'll say about it, some of that is going to be a part of our strategic planning process. I mean, that's what the whole point was, to get this done in time for our strategic planning process. There's two really major things that we haven't learned from this report through nobody's fault. One of them already came up, is need. How do we get at need? I don't know that anybody really has that answer, at least not yet. And the other is impact. How do we measure the impact of our system? And I don't know that we got anywhere close to that, but I think that the next step would be to take this knowledge into the strategic planning process and go from there.
Great. Zafir.
Hi there, y'all. Forgot to mention this earlier, but what I focus on is very multifaceted. I am a Black youth, I am an autistic youth, and I am a queer youth. Besides the fact that some of those things didn't seem to be represented in the data that was shown, it does seem like if there's so many unanswered questions and missing data, that it may be more inconclusive. Maybe I'm missing something. That could very well be it. I haven't read the 200 pages. I can't say I have, but it does seem like there's a lot of questions in comparison to the data that was got. So I'm trying to think of how to phrase the question. Does the team that worked on it feel like it's a proper representation of all the groups and youth that they are serving? Or does this data feel inconclusive? Because just from the presentation, it does feel like there are even just specific groups that were not represented in the data as extensively as other groups were. So I just want to see how people feel about that.
I can take that one. Yes, that was a really big challenge that we had. And I think I saw it in the chat, maybe Alicia said, we did comment on it throughout the report pretty explicitly when we weren't able to find certain data or when we weren't able to stratify by demographic groups, which is what we originally wanted to do. When we developed the questions, the question answer format, each one includes an equity lens. And so the second every single question is, are there disparities? Are there certain groups more affected by this than others? And because of some of the challenges in the data entry or data request process, we ended up not getting a ton of individual level data. And so it was harder to stratify by these really unique characteristics. where instead what we got was a lot of aggregate data where they only provided race and ethnicity, and that was the only demographic factor or something like that. So we agree that that's a big limitation, and one of the recommendations is definitely to try to obtain more of that individual level data so we can really look more closely at what groups are being impacted by these different data points. So I think that's kind of the response for that half of the question. I think in terms of missing data and kind of feeling like it's inconclusive, the questions themselves, as you go through the report, how it's showing there's like the blue boxes with the questions, they're pretty, I mean, they're all interrelated in that they're all about the system of care, but they're really meant to be like standalone questions. So there's a question about access to mental health care, which is the graph that, or the maps that I showed earlier. And some questions we were able to answer like pretty fully. We had demographic data. We feel pretty confident in the response. Others, we were limited by looking at like literature reviews, or we weren't able to get any data from the system. So each question has varying degrees of completeness, and that's in the appendix. We kind of comment on that and say, these are the things we weren't able to get for this question. And we also tried to, like Alicia was saying, put it within the narrative too, of like this part of the question is missing so that it's super clear to people as they read the report, kind of how to take in that information and how representative it is. Does that answer, I think, both the questions?
I think so, yeah. Thank you.
Okay.
I would
Thank
just
you.
add too, thank you, Amanda, for jumping in. It's not kind of an all or nothing here. I think there is a lot of value in the report, and there's a lot more that still needs to be asked and answered.
Definitely.
Oh yeah, I don't want to seem like I'm just, thumbs down Spartus on the report.
No, you don't.
But what I'm saying is that it does still seem that, like, let's say there's 75 questions and 23 of them are missing data. That seems like it's doing less help than good in the long run. That's my main concern.
And that's also an indication of what data needs to be collected. Right.
Absolutely.
And so that it conclusive or inconclusive might not be the frame. It's what did it reveal needs to be done. Right.
Hey everybody, and thanks OHSU team for your presentation today. We've heard a few times about the vastness of the report being 200 pages, and I'm sure that's intimidating to a lot of folks. Do you have any recommendations on how to jump into the report, or a recommended way to start reading it or diving in?
I can take that. I think starting with the executive summary at the beginning, it kind of goes through the 6 questions and pulls out highlights. And that was what Amanda used for the framework for her part of the presentation. And then I think if there's a system that you feel particularly invested in, start with that chapter. There's also a, what's it called, Amanda? System population overview chapter, the one at the beginning, that kind of lays out more cross-system data about the makeup of youth who are participating in different systems and some kind of basic comparison points. So that would also be a helpful place to start. Cody, you've read the whole report at least once. What do you think?
I agree. I kind of knew the answer to my question already, and it was more for everybody else. But that's why we asked it.
Yeah, also copy.
Yeah. Go section by section, folks. Nobody in the world has the capability of sitting down and reading this in one go. So don't feel like that's what it's meant for.
Challenge accepted, Cody.
I don't know about that, Adam, but you go for it.
Just a few pots of coffee, my friend. Alicia.
I hear coffee and I get excited. So anyway, what was my question? Okay, so first I would actually I want to acknowledge that the work that the OHSU team put into this, or the data team put into this, is great. And having been part of a lot of those discussions in terms of the how the questions are asked, what type of questions are asked, it 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 was a very frustrating, sometimes very frustrating process for me as a family rep to sit in these spaces and be like, wait a minute, that's not even a question we should be asking, right? If you want to know XYZ, don't ask this question. You need to ask something else. And then data team came back and like, well, this is all we have to ask, right? So I want to acknowledge the work that everybody's put into this, and then also elevating what Saphir said earlier, because it's trying to measure something when you don't have the right answers or questions, let alone the actual data to go with it, is very frustrating. With that said, as I put in the chat earlier, I would love to try to figure out a way for us to get this report in front of the Family Advisory Committee, for us to to look at it from kind of like the family member and caregiver lens. And I wonder if y'all have maybe a little bit of a more detailed PowerPoint than the one that we just saw, that I could utilize or kind of move or use over at the Family Advisory Committee. And yeah, so I wonder if y'all have anything like that available.
We do not. This is our only PowerPoint. But if you but if you let us know, Alicia, what you need, we can try to figure something out. Like, what kind of details are you looking for?
I don't know yet, but I will get back we'll get
Yeah,
back to you about it. And yeah, we could take that I guess that conversation offline. I was just just wondering, and I agree with what Andrew was saying, is that I'm hoping that we can utilize this information that you all put together and use it for strategic planning. I think it'll help us a lot in terms of plugging in this information to strategic planning. So I appreciate it.
Good with me.
Hi, I have a question from a family member with lived expertise. Becky and team, does this report have any information about youth who do not qualify for mental health services due to having a disability? And did your research identify a way to support both simultaneously, or give you ideas about how to support both? Thank you.
Is that specific to like IDD, or do you mean?
Yes.
Yeah. There is a question in the IDD accessing care. And so we do have some information in there. Does it say, did the family member say more specifically like what they were interested in?
I think really the question is about, for some kids who are not able to access mental health because of their diagnosis and having it already be seen as accessing services through IDD. A lot of kids with disabilities do need mental health services and IDD services, but that's the question. That's the intersection where the question lies.
Yes. So we do specifically talk about mental health support for the IDD population. That's in the IDD chapter. And we do comment on kind of this issue of what's in rule versus what the actual experiences of families and youth. And so we have a little bit of information in there as well.
And we got, some of the places where we weren't able to get data that we were looking for, that was one of the reasons that we did the family survey, because we really wanted to represent the experiences of families in areas like this where there might not be adequate data to represent what people are actually experiencing in the community.
Yeah, and if I can piggyback onto that, and maybe Alicia, we can take this to the Family Advisory Council and the Youth Council. That when we talk about using data to answer these questions, there's a limitation to how much data is even collected on family and youth experiences and what youth and families continually share in committees, in councils, in advocacy spaces, and all of that, but it's not necessarily captured in the same kind of way as ongoing data collection within systems and services. And so this can be really super frustrating for us because we feel like we're beating the drum, we're saying over and over the things we're saying, and yet somehow we experience it not being heard. And sometimes we can think about how do we want to have this more intentionally organized in data collection. And for example, in CATS, we collected data from clinicians, from the family peer support specialists, and the families. And that created some really robust data for us to look at program and service improvement, workflow improvement, and outcomes. And so that's just not commonly done at the level of data collection within systems, within subsystems, and within services. So how we do that and who we gather to help champion us to be able to do that, rather than the episodic survey and or the the ongoing verbal that we give in every single committee and group that we sit on, might be a really important way for us to think about getting our thoughts and knowledge and expertise into the data pool.
Thank you all.
All right, well, thank you all for joining us. We've got a lot of reading to do, but it's all really awesome, and we appreciate the effort and energy and commitment that y'all have to everything that we're trying to do in Oregon to make things better for kids and families. So, like, we're grateful to you all, and I look forward to continuing to partner with you. So we're gonna head to break here in just a moment. Before we do, I just want to make it clear. I was asked, little birdie asked me again to make it very clear what I brought up earlier about the System of Care Advisory Council Omnibus Bill. We're going to dive into that work after public comment. And so the amendments that have come out recently that y'all got the email for, I believe, yesterday, that were represented that it was in collaboration or partnership between DHS and Disability Rights Oregon. I want to make it very clear that Disability Rights Oregon does not support the proposed amendments, and it does not reflect the position of Disability Rights Oregon as it came out in the email. So just want to lay that out there, make that very clear for the record as we get into that coming up after the break. So with that, we do actually have a 20-minute break. Okay. Emily, then I'm confused because I have openly, I'm going to ask you to speak to it for the next couple of minutes. Sorry, because I have a very clear statement here that the proposed amendments do not reflect the position of Disability Rights Oregon. And so you are an employee of Disability Rights Oregon. And so in the chat, you're saying you support them. So I'm just going to give it over to you for a couple of minutes. Because I don't want to, I'm reading,
Mhm.
And you're posting something different in the chat.
Yeah, thanks, Adam, because I think clarification is really important. And so email went out saying it was in partnership with the Arrow. And what was hard is the two-pager responded to about 10% of our concerns. And so we think it's absolutely the right step. And we should continue to look at the bill, make amendments, make sure there are no inadvertent mistakes. So it's not that we're against what ODHS is trying to do in terms of amending it. It's more, it doesn't represent all of our concerns. It represents about 10%. So it's not like it's something we jointly wrote that two-pager together and said these are the amendments where if they're made, the Arrow is now happy and our concerns are addressed. So that's what I wanted to clarify. Does that help?
I honestly don't know if it does or not. Like being full, like just keeping it real. Like, I don't know if it does or not because I posted in the chat with this Jake Cornett, who's the CEO.
That's my boss.
Yeah, right. Put in there. So I'm just making it very clear at his request.
Yes, thank you. It doesn't, the two-pager does not reflect the entirety of our position. I think I 100% agree.
I'm not, if that is the context that you would like to add, that's great. I'm definitely not adding it. Neither is the System of Care Advisory Council. I, I see Lacey Andreessen has her hand up. I'm honestly hesitant to get into the back and forth about this, but
No, Lacey and I get along. We're good. We're good.
it doesn't seem like it. Like based on the emails that have been going around, I'm just being fully transparent. It doesn't seem like folks are getting along right now, and there are personal attacks being made that go against the values of the System of Care Advisory Council and our shared agreements. So I'm going to let Lacey make a comment, and we are going to go to break at 2:25 for 15 minutes, and we'll come back at 2:40.
Thank you, Adam. Emily and I are able to communicate with absolutely in alignment with the values of this council, just so you know. I wouldn't raise my hand if I couldn't. Emily, do you think it's fair to say that the changes that have been proposed, although not fully encapsulating all of DRO's proposed amendments, have been created and crafted in partnership between us and you all?
Yes, I think it's a beautiful first step, but there's a lot more steps before I could say we're in partnership.
Okay. With that, Zafir, can we take a break, or I don't want to be rude.
Oh no, yeah. I'm down for the break.
Okay. So we're going to take a break. We're going to come back at 2:40 for public comment, and then we'll go from there. Back. We've got 1 minute, but if you're back and a council member, if you could turn on your camera so that we can see that you are back and ready to roll.
Adam, this is Kati. I am back, but not able to be on camera right now.
Fair enough. Thank you. I guess I should say, yeah, like, or maybe raise your hand, right, or something like that if you don't want to, if you're unable to be on camera. Thanks, Kati. Well, it is 2:40, and I want to be respectful of those who have joined us for public comment. So I do want to open it up for public comment. If you wish, you can privately chat Joylene Carter, Alicia Overstreet, or Annette Magicotomy. If you have questions or comments that you would rather have someone else say for you. Otherwise, raise your Zoom hand or actual hand, and I will call on you. So any public comment today? Zafir, I know you're a member of the council now, but we don't have anybody else, so go for it.
Okay. Yeah, that feels weird. I don't get to be part of public comment now. Whoa, this is so cool. And I still get to crochet. I guess my question specifically was more so for Emily and DRO, but I don't know if she's back yet.
I do not know either. But I think if she's not, we can make sure that you get an opportunity to ask that as we dig in, because I think most of the rest of the day is talking about the System of Care Advisory Council bill. So,
Okay.
Any other public comment? Any last thoughts on cereal and soup? For those of you that weren't able to join us before we got started, that was the question of the month: is cereal a soup or not?
Want y'all to know I'm not budging on this one.
Dan Toma has very strong feelings. And
I'm back in Dan. I also have strong feelings.
We can be divided and yet still care and be kind to each other. And that is the important lesson here. Alicia, go ahead.
Yeah, very strong feelings. It's not soup.
It is soup by the definition of soup in the constitution of a bowl of milk and cereal. It is soup.
I'm not gonna, sorry to derail us, but there wasn't anybody in line to present public comment. So I'm just trying to bring some levity to the situation on serious topics. And Adam, it's not the first time I've offended you, my friend. Probably won't be the last. So if there is no other public comment, I'll give kind of a 10-second pause. And if not, we will move to Annette and our next topic.
Adam, I do have a I want to go back up here in the chat, and I think one of the family reps shared a training from OHSU, I believe.
Yeah, I can. Looks like it was Amy Fellows. I can copy and drop it back to the bottom of the chat.
Yeah, that would be great. So we can just go ahead
I just did that.
Oh, okay, cool. Yep.
For you.
Thanks, Amy.
Doubled it up.
Yeah, and there'll be more that I can continue to share with SOCAC. And their OHSU Echo is working on creating one that's more directed at mental health providers that work with IDD youth.
Right on.
Adam, I see Jenny's hand up, but I just want to, if it's okay with you as the chair, if we would read out what's in the chat that Amy just shared, because the chat does not show up on the recording when we post these meetings to the Zoom, to YouTube.
I can do that. OHSU Office of Disability and Health is holding a training for mental health providers to learn to better support people with intellectual or developmental disability. The Office of Disability and I'm not sure what OODH is, but mental health care provider training webinar to this upcoming Tuesday, March 4th. That was today.
Oh, oops. Sorry, I didn't catch it was today. I'll share the next one. I think they're going to start having them monthly.
Yeah, cool. Right on. Yeah.
Okay, sorry about that.
No, it's all good. It's great.
I forgot we're in March.
Yeah. So we missed it, but there may be more to come. So yeah, we'll keep track of it moving forward. Jenny, go ahead.
Yeah, I just because like Anna said, what was in the chat doesn't show up. I just wanted to mention again that as far as the D in Real D goes, I would really like to see Oregon start to address that because it's been several years that families have been bringing it forward that they're not taking data on the disability part there. And so I just wanted to say it here on this record that talking about it over and over again doesn't seem to change anything. So I really hope that I think at the CSAC meeting, it was mentioned that in a couple of years, hopefully we'll have that data. It feels kind of unacceptable.
And am I correct, Jenny, in like you're referring to state agency data collection systems that are not identifying individuals with disability? So
Yeah, that data is not being collected in a lot of spaces. And so I would really like to see that change.
absolutely.
This is not to counter Jenny's point, but to add context to it. The Real D law that passed in Oregon applies only to mental health and physical health care providers. So the Department of Human Services is not currently included under that legislative mandate. That's not an excuse for them to not gather that data, but the law that when we hear about Real D, that's specific to healthcare settings in terms of what the legislative mandate was when that original bill was passed. So that may be one area for advocacy that folks want to consider getting involved in, is expanding that law to cover more types of data gathering than is currently included under that requirement.
Yes, and also it's still not always being taken when it comes to medical either. So.
Sure. Yeah. And I'm not arguing with that at all. Yeah.
And just Jenny in the chat, Christy Hudson mentions that we, System of Care Advisory Council team staff, are actively working with OHA, Oregon Health Authority, and the Office of Research, Reporting, Analytics, and what's the I in ORA? Sorry. To add real D data to the System of Care dashboard. So it sounds like we've got some active work going on there.
Trying to push and pull on that system.
Okay. Alicia, you are also a council member, but go for it.
Yes, I just wanted to share something really great that George Fox University put on earlier this week or over the weekend, and they actually had an interprofessional event or education event where they invited students from their PsyD programs, their PT, OT, mental health, and licensed clinical social worker programs, and actually had received some education and got to do some engagement with family members as well as professionals who work with children and youth, as well as beyond kind of our age range that we focus on here, with that population with IDD, and how it kind of intersects with how IDD and physical and mental health all intersect, and how to work with clients who might have those intersectionalities. So I just wanted to give a huge shout out to George Fox University, and I really, really appreciated them putting that on.
Right on. Very cool. We are at time for public comment. I know we used a couple of minutes from council members. Is there any last public comment?
Maybe read out more information from Amy Fellows about opportunities to engage in IDD and mental health. Put in two more
Yeah.
in the chat.
There's one on August 6th, the Youth Intellectual Developmental Disability Mental Health Summit for mental health providers, DD system workers, family, youth, educators, really anybody. And there's a link. It's iddmhsummit.com for those of you that are maybe listening to this. Keynote speakers, Guy Stevens from the Alliance Against Seclusion and Restraint, and hopefully everyone in the writing of this bill, I think that's referring to House Bill 3835, the System of Care Omnibus Bill, will be interested in attending since it's directly connected to the work of the System of Care Advisory Council. And then another link that is endseclusion.org. And with that, we'll close public comment and pass it to my friend Annette. Unless Annette's not here, I don't see her on camera. Oh, there you are.
Yeah. Thank you, Adam. Thank you, everyone. We're going to just do an overview of the GARE review of HB 3835. Anna Williams and Cody Welty will also be assisting in going through this, as well as any DEI subcommittee members. Feel free to chime in and where needed. So, thank you. Is someone going to share the?
I can, Annette. Sorry, I wasn't sure what the process would be. Let's see if I have a
Right,
permission.
right.
Oh, Anna's got it. She's quicker than me.
Ah. Thank you.
Anna, if you're talking, you're muted, just so you know.
All right.
Annette, I think this is where you wanted to start. Is that accurate, or would you like me to
Yes.
navigate somewhere else in
Yes.
the document?
That's it. That's where it is. So analysis and strategies, and what are the strategies for advancing racial equity? Actually, the subcommittee met several times, met in January and also February. February is when we actually went through the bill. We're very deliberate in ensuring that we got it right, or to a point where we reached an understanding. We did that last Friday, I believe. So here's what we have. Overall, the LC would have mixed effects on racial equity by each section of the LC. The impacts are summarized below. Restraints and seclusion definitions. It is not known if clarifying definitions of seclusion and restraint will disproportionately affect special racial and ethnic groups, children with disabilities. Out-of-state placement. American Indian and American Native youth would stand to gain the most benefit from change in exceptions to out-of-state placement, as they currently are more likely to be shut out of these types of services. This would increase racial equity. We did have a concern about this concerning African American youth. I believe Alicia was brought that out there, that updating it to not say that African American youth will be better served by an out-of-state placement, when that's not necessarily the case, or it shouldn't be the case. African American youth should be able to get the services where they live. Investigative process by ODE. ODE as an independent investigator, as opposed to the current system of internal investigations by the school district, may provide more transparency to youth and families who are impacted by institutional racism and/or ableism, which would increase racial and disability equity. Interdisciplinary Institute at OHSU. Depending on the activities of the interdisciplinary team, there is potential to either positively or negatively impact health equities. Video use in restraint and seclusion. This is something that we really delved into. It seems like it would not necessarily help kids in schools to have video of them. So, because it's more likely to be used as a punitive, something punitive against kids, and essentially lots of times kids of color. or would tend to be harmed by this. In conversations with youth and families, we have heard concerns about the following: increased use of ABA or other behaviorism-based interventions, behavior modification, which have caused trauma and PTSD for children and youth with disabilities. Inadequate training and support resources for staff leading the implementation. Fears redefining terms of abuse and seclusion and restraint make it easier to impose wrongful seclusion and wrongful restraint. Fears that child welfare may use newly created option to place children in care in out-of-state facilities leads to foster youth being placed in unsafe, unregulated, and inadequate facilities. Concerns that providers and agencies may increase the use of behaviorism based on behavior modification interventions due to the addition of new approved intervention strategies, as well as it relates to the concerns of increased use of restraints and seclusion. Similar concerns were also expressed as a result of the bill. There will be a decreased likelihood for providers to use science-based alternative interventions which focus on the root cause of behavior rather than modification of existing behaviors. Family advocates also express fear that this bill could lead to an increased use of restraint and seclusion.
There's a question in the chat that says, was that supposed to be neuroscience based? I'm not sure, Amy Fellows. Are you talking about the concerns that providers and agencies may increase the use of behaviorism-based interventions?
Where it says science-based. I was wondering if it was supposed to be.
Specific recommendation from Alicia, so maybe Alicia can.
Oh, science and not neuroscience. Okay.
Yeah, it was a my bad. I wanted to say neuroscience based, but I put science based. Either way, it's more science based than behavior modification.
Yeah, just harmful things come in under the science-based umbrella. That neuroscience is very specific to child development and other things.
That was that wasn't my bad. It was supposed to be neuroscience based interventions or alternatives. But yeah, and I mean we can make a note.
Yeah.
Adding that.
Yeah.
Clarification.
Thank you.
Wouldn't be my first edit in this document, so don't worry.
Right. Thank you, Cody. Benefits that may result from this concept include the following. Oregon's children and youth have more options and access to quality providers closer to where they live. Tribal children have access to culturally appropriate care. They are currently denied due to involvement with the child welfare system, a violation of the Indian Child Welfare Act, ICWA, and the Oregon Indian Child Welfare Act, or ICWA. Children in the custody of child welfare will have access to the same specialized medical services as other Oregon children on Medicaid or in the juvenile legal system today. Secure transport services providers will likely resume providing secure youth transport services in Oregon. Increased capacity for agencies to provide medical and behavioral health services and supports in children and youth. More programs have increased staff retention for programs that certify, support, and oversee foster parents who provide specialized behavioral health treatment supports. Fewer children are in temporary lodging and reduced boarding in emergency departments. Clear and consistent definition of third-party child abuse across all regulated settings make it easier for children or for youth and families to understand and advocate for their rights. This bill is a step toward building a trauma-informed children's system, which learns from mistakes and prioritizes healthy relationships between youth, parents, caregivers, and regulatory bodies. Anyone from DEI want to make a comment on what we're seeing so far? Okay.
There's a question in the chat, Annette, that I responded to. It's curious what the new interventions that might increase risk of increased restraint from the bill. I think, yeah, okay. Alicia confirmed. Yeah, okay. So that the bill allows for discussion of adding new crisis intervention programs and to the current models. And so some of those, I think folks have some concerns of like possible models that could possibly be used would be concerning to folks. So, okay.
Yeah.
And of course,
Robin.
in the bill, we're not going to get specific about which models they would add. That would move towards the licensing, rulemaking policy part.
Thank you.
One would
Robin?
hope that the section that we included in there, that the any new intervention strategies would be added at the recommendation of a family advisory body, would prevent that from that the families would not choose new intervention models that would cause them concern. But I think it's important to note that the part of the bill that says we will add more says that it will be DHS will be in partnership with a family advisory committee for those additions. So if the families want to recommend more behaviorism based stuff, I guess that could happen, depending on who they select, or however that ends up playing out. And so that's why it's included as a concern. It's like making sure that the devil is in the details in terms of implementation, right?
Robin.
Yeah, I had a question going back to initially when we were talking about out-of-state placements and the focus in there on the benefits for Native American and Alaskan youth. Just wanted to call out that part of where I've seen the applicability of this comes is less in definitely in culturally specific areas in that, but also in where we have youth who are on the borders, like the Idaho border, and you're closer to Idaho than you are to the great state of Portland. But more important than that is for specific diagnostic categories that Oregon just isn't big enough to host, specifically acute eating disorders. It is really, really hard. We're not large enough as a state to fully support adequate full range of continuum for eating disorders, and we have to rely on out-of-state partners. And I really want to see and ensure that youth who are in child welfare can access those resources when they need them, because we're never going to be able to support them in Oregon. Thank you.
Thank you, Robin. Alicia?
Yeah, I just wanted to Robin's point, I just want to reiterate that while I am not the biggest fan of this tool, I also just want to make sure that we put it in the context that this really is the racial equity tool, and we didn't necessarily look at the types of treatments or diagnoses that aren't necessarily being served in the state of Oregon. So I just wanted to highlight that difference. And then, but it, maybe in the future, we can actually have a process like this that is inclusive of all the different, types of demographics and things that we're trying to look at. So I appreciate the point, but I just wanted to make sure that we are all on the same page in terms of that this particular tool really looks at the racial equity piece.
Thank you, Alicia. And Emily?
I think it's a good point. And I think GARE is designed to look at racial equity, but I think part of where I start to get nerdy and think about the OHSU presentation is what we also know about overrepresentation. And so like, just follow me for a moment. So we know, for example, that based on the OHSU report that I've only read briefly and skimmed, is that there's a disproportionate number of children who experience intellectual and developmental disabilities not having access to mental health treatment, right? But we also know that same subset tends to be overrepresented by white kids compared to what's in the community. And so this is where I do think when I think about the impact on this bill, I think it's, you know, there's going to be multiple identities of youth that are going to be impacted by this. But I worry about when we think just about racial equity, that we're looking at kids who have been disproportionately discharged or kicked out of school, expelled from school, overrepresented in OIA. And so I'm really glad you all did this work. And I know it must not have been easy.
Thank you, Emily. It wasn't easy. Thank you. April?
Good afternoon. I was going to put in the chat, but I wanted to ask a clarifying question. Alicia, I appreciate that you put, that's if ODHS uses the recommendations from the family group. And I'm really curious about where the if comes from, and where we can, as partners in the System of Care Advisory, maybe come and talk about the level of community voice and engagement and advisories, and how we are really, really trying to lead with community voice. And I think because child welfare's advisory and community engagement is not integrated into the work of System of Care necessarily, there could be a lot of folks that have no idea how much our leadership, my leadership, our vision, our mission, the work that we are doing is coming directly from voices of family and community that may be outside of the System of Care Advisory. It's something that I brought up in other spaces because I think sometimes we might hear a story or something that has happened with a family or community member, and the assumption is made that there aren't other voices at the table with ODHS directly in the regular course of us, writing rule and writing procedure and developing policy. And there's a couple of folks that are here, I think they're here on this meeting, that have been doing some incredible work around aligning our community engagement efforts. And I think it's worth just offering to the committee for that group of folks to maybe come and talk about how we're sharing power with family and communities as child welfare. I don't speak for all of ODHS. Let me just speak for child welfare and what we mean by sharing power in an equity space. We're actually getting a lot of national attention around it. And it just dawned on me that our Oregon partners don't even know we're doing this work. And so the if concerns me. And I want to know what we can do to help, at least with this advisory, build some confidence that the voices of the community don't just mean a lot to me. They mean a lot to everyone that I'm working with in this iteration of DHS. Maybe not DHS 10 years ago, but the DHS of the last 5 years, we have been working really, really hard to make sure that the recommendations and feedback that we get from community, to the best of our ability, we are moving forward with that. And so I may be, changing the subject just a little bit, but I think because of the impact assessment tool or the GARE tool, if it's highlighting areas where us as a particular agency, and I will say ODHS gets called out a lot in these spaces. And I think because we're talking about changes that will impact foster children, we get called out. But I think, my understanding of the goal of System of Care is really to improve outcomes for everyone's children in our state. If ODHS is going to be called into behaving better and doing differently so that there's more confidence that the voices of community are going to be listened to, that I want to at least have the opportunity to come and talk with you all about how we are sharing power with community, and willing to take feedback on places and spaces where I or my team have contributed to a lack of confidence that there are voices of people with lived experience that are driving what we do. Again, I don't speak to the entire child serving system. So when it comes to rule writing and things like that, where, other systems that support children, obviously I can't speak to that. But I can speak to the fact that we are, in the spirit of good partnership, really wanting to make sure that the folks that have lived through and are living through the challenges within our systems are being heard, are being seen, and are feeling that we are demonstrating that commitment in everything that we do. So my commitment is to working on it. And if we have to come back and forth in front of the council and talk a little bit about some of the things that we're doing that system of care may not know about, I'm happy to do so.
Yeah, no, April, I appreciate it. And my comment in the chat in terms of if ODHS, I guess takes the recommendations from the panel isn't or wasn't necessarily meant in a derogatory way or, to attack any of the work that you've done. Because I think you and I, we've had multiple discussions, right, where we're just like, oh my goodness, like we need to be able to get some of these things done. And the only way that we can get, XYZ done is if we work together, right? I would love to, come to some of the spaces that you're talking about and see it. I think two reasons why I put that in there or in the chat is one, experience that I've had or that family members have shared with me in my community and around the state, with their experiences with child welfare or ODHS as a whole. And those are experiences from like 6 years ago all the way to 2 weeks ago, but that was more in terms of kind of the family voice, what I am hearing, right, within the community, which again, can't blame you if you can't, if you're not hearing every individual voice that's engaged in the system, right? And that wasn't my intent at all. I think it's just more of a, that's what's, many of the family members that I engage with who are engaged within that system, that's some of their feelings. With that said, second reason why I put that there is because whenever I suggested that this family and youth panel be created, I didn't necessarily ask for ODHS to, out of all the different recommendations that would come out of these discussions, that ODHS would at least utilize one crisis intervention system, right? So that's what I meant by saying, if ODHS listens to the recommendations, because within the statute, and maybe that's an amendment that we need to do, and I didn't even think about it until just now, right? But if it's not in writing, it doesn't exist, right? So that's kind of where where that comment came from. So it wasn't necessarily in terms of anything that you did. And I hope it didn't come across as me trying to call you or your work out, because that was not the intention at all. But I hope that clarifies what I meant with the if ODHS, listens to those recommendations.
I'm just putting the offer back out there. Anytime, system of care, if we can come and do some work on some of that in terms of community engagement, that was really, the intent of my response was we got to work on it, and I'm happy to.
I think,
Thank you.
April, in response to that, it's really important to also consider how all of that community engagement that you're doing will inform the System of Care Advisory Council strategic plan. I know we sent out a request to all of the different system leaders who host community advisory bodies to kind of think about how they'll gather that data and use it to inform the System of Care strategic plan. But I do wonder if in a shorter term, and this is maybe a suggestion to the executive committee, we want to consider better understanding what community advisory work is happening in other spaces, because I do think there's a broad lack of trust that systems are trying to hear or responding to what they hear from in youth and family who are impacted by their services or supports. So that may be a good recommendation for the executive council to put on a future agenda.
Thank you.
We've got 4 minutes left. The main concern that I saw in there, and folks can correct me if they feel differently, about possible negative equity impact was related to cameras in schools. So I guess the question to me is, do we want to look at pulling that out of the bill? Do we feel like we're prepared? Do we know enough to make a decision like that, to make a motion? If not, like maybe I'm the only one that's even considering something like that. I don't know. Just going to put it out on the table.
Robin?
Yeah, I did read that section of the GARE analysis, and have done a lot of thinking about that. And I see it. I see it. I see that we can't protect against bias across the spectrum, and those cameras could be used for retaliatory purposes. And I just don't know if our system is ready for the education system is ready for that at this stage in the game. I would support pulling that out at this point on their recommendation. And I'm happy to put a motion on the floor if you want, Adam.
I wonder if we could, would it be too late if there's a, would it be too late for us to have a deeper or more in-depth conversation about that tomorrow during the lunch committee meeting, since we have multiple of the family members who are part of that process or were part of that process during the lunch committee meeting too, so that, it's not necessarily, I want to ensure that, if we're going to pull something, it is, led by the people who initially suggested it in the first place, and, with all the information that we have on hand. And I'm okay. If I'm wrong about that, that's totally cool. I'm good with it. I just wanted to throw that option out there too.
Sandra and then Emily.
I think what I would like to say is, so I've been working in the juvenile justice system now for about 20 years. And from my experience, and I can't speak to the side of like how it would benefit youth or how it would keep youth safe or help us in school settings. It's a different, I think it's a very different ball game in detention settings, but in school settings, it is my experience that it will be used. It could quite likely be used to or refer youth to our system who are there for different reasons. And I've seen it over and over again. And I do think that it will disproportionately impact our brown and Black youth, and certainly schools that have SROs or law enforcement assigned to their schools. I do believe there is potential for a negative impact. I've just seen hundreds and hundreds of referrals come through, and I've seen 10-year-olds be referred to the juvenile department. I've seen just things that I would not have liked to have seen. And it's not to say that I would not like every youth to be able to get support and intervention, but I do not believe it should come into our system. And with video recording, that is an awesome way to prosecute. And it's just evidence that is no way to, even regardless of the situation. So I don't know. I think it's great to include, talk about it tomorrow, whatever, but my 2 cents is that it could have a negative impact.
Thank you. Emily, did you have a comment? I saw your hand up.
I just didn't know. I mean, I didn't know if it's part of the conversation was just that tension of like dash cams and law enforcement wearing cameras has also weeded out some terrible atrocities that have happened to Black and brown communities. And so while there is, it's a double-edged sword, right? Like I hear what you guys are saying, and Sandra, you in particular, like the concerns about this being used against youth of color, I think absolutely should be highlighted. Is there any sort of countervailing thought that it could also be used to like just, show wrongdoers? And I don't know what the conversation was. I was just curious to know if that was part of it.
I can answer that question from Emily, if that's okay. Emily, we did look at that, and unfortunately, there's no evidence that using cameras actually helps reduce instances of seclusion and restraint, or child abuse, because any perpetrator would know where the camera is. And in a lot of the documents that I've been reading, it's very easy for folks, when they know where the camera is, to either move their body in a way that blocks the activity. And it also can provide a false sense of security for the kiddos that are in this situation, where they feel like they're safe because of the camera, and that's not the case. We pulled up the larger section from the GARE, if folks want to read it while we're here. But that's the answer to your question that I have, Emily.
Yeah, I just want to note also in the chat, I've received some requests from parents and folks with lived experience that maybe we need some more discussion about that before we take a vote. So it sounds like there's significant concern about having because right now in the bill, it is required that video be present and available. So the discussion is, do we want to pull that out of the bill? We're at overtime for this part of the topic. It might come up again later, but in the next hour. But I think then what I'm hearing is we're not in a place where we're looking for a motion to take it out right now. And I haven't heard that, and we'll move the discussion to the legislative committee. And then we, depending on timelines, that's where it gets sticky, folks, around the full council versus legislative council or legislative subcommittee is just about timeline for amendments. So we'll move it to the legislative subcommittee for now. And then we'll see what comes of that, and we'll go from there. Sandra, is that a stale hand raised? No, it's a fresh hand. Oh, it is a stale hand. Okay. Alicia, did you just have a quick comment on this before we move to the next topic?
Yeah, actually, I was gonna say that we can go ahead and just make a motion to remove that section the video. Oh my goodness, to remove that portion out of the bill. As I got some feedback from some of the family members who were involved in that whole process, and they are okay with getting removing that section of this bill.
Now I'm a little okay. So I've received some information. There are family members that are concerned and want more discussion. You've received some information that some family members are ready to go.
Mm-hmm. We can still have a discussion about it. So I mean, if that's the case, I was just saying that the individuals who were part of kind of the reason of getting that in this bill are the same people who reached out to me during this conversations or during this conversation and said that they would be okay with removing it. Having said that, if we're getting kind of two different feedbacks here, then yes, I would err on a side of caution and then move it to the legislative. I just wanted to let you know that the people who were part of this discussion initially, who initially proposed this particular portion of the bill, reached out to me and let me know that they would be okay with removing it at this point in time.
Well, I'm just one of 25, so like don't let me, sway anybody. So if somebody wants to make a motion, my only concern is that if it doesn't pass, then it's in there.
Well, if it doesn't pass, we can always continue the discussion, but I haven't heard anybody advocating for keeping it. I've heard questions, but I haven't heard anybody going, no, I want those cameras. I think we could have the conversation. Alicia, if you're comfortable and the family members have reached out to you and said, we would like to have this out, and they're the family members who were involved with the DEI conversation, that would be fantastic.
And Jolene has put in a chat more information from me now, have their questions answered. So we can still do both, right? And still have a conversation about this particular topic, but it doesn't necessarily have to be directly tied to the bill. But we can still have, over the next few months, a good and wholesome conversation about whether this might actually be positive, or something like this might be positive for disabled kids in schools and other and marginalized children and youth and students. But we don't have to do right now with this bill.
Okay, what are we doing? Are we moving to ledge tomorrow, or are we having a vote here?
No, so I'm making a motion to remove this particular piece.
Okay.
Out of the bill.
Okay.
Based on the information that I received from the family members.
Alicia, is it okay with you if I'm just really specific about what we would be removing from the bill so that we're all really clear on what it is that we're discussing?
Oh.
Like literally the line and page numbers? Because I know where all of it lives in the bill, right? And so I just want to make sure that we know that like what it is that we're sort of recording on camera, what we're talking about.
Anna, could you pull it up and show it to everyone so that they can see it? And that way everybody can get a read at exactly the language we're deleting.
Yes.
That way we're proposing to delete.
Yes.
And yes, while you do that, stale hand, right? So like I sometimes use the term old hand, but like that's rude because I didn't want to call it an old hand, so I called it a stale hand because it's been up there a while. It's just stale. So
got it. Stale is way better than old.
So if we wanted to amend out the camera section, the camera requirements in the bill, it would be two separate places within the bill. It would be, oh, sorry, it's probably too small for you. It would be here on page 8. Require the rooms to be equipped with operational video recording equipment. We would just be deleting actually from line 29 where it says : and all the way to this period in line 30 after equipment. That just gets deleted. And then close your eyes for a second. If you get motion sick, as documents whiz by. The other section we would be deleting would be on page 64, lines 34 through 36. This section that just is the implementation timeline for the State Board of Education to require the cameras for the 26th by the beginning of the 26-27 school year. There's nothing else in the bill that addresses cameras in schools. So if we deleted those two things, that would pull the topic completely out of the bill.
Jenny?
Yeah, so just to be clear, the video cameras would be in the involuntary seclusion rooms only?
Let's go back to that section and just double check. Yep, they would be in rooms used for seclusion.
Okay. Yeah, this is complicated and nuanced. I don't know really what else to say right now about it.
No, it is, right, Jenny? That's just it, right? It's like, well, because, you know, having it in those rooms could prove duration, right? So that school districts, you know, there would be proof of the duration that they were secluding children. It doesn't capture when the actual like restraint or movement happens. The video.
I would encourage folks.
I do think it's something to think about because, you know, I'm trying to like in my head picture the many police reports that I have read with involving different videos. And a lot of it will be destruction of property. A lot of it will be kids. Yeah. So, and I mean, when I'm thinking of a seclusion room, maybe those type of like that possibility is not there. And then of course, just physically acting out and a staff getting what they might consider assaulted or something.
Yeah, Cody, was there more you wanted to? Oh, sorry, Zafir. Cody had started to talk as well. I didn't know if there was something you wanted to finish saying, and then maybe I'm taking it over again, Zafir.
I would encourage folks to read the resources that are listed in reference because they answer a lot of these questions. I don't have a lot of this info memorized or off the top of my head, but there are a lot of disability rights groups that are opposed to including cameras in these rooms, and there's a lot of reasons included for that. I would also note that Maryland tried to adopt this kind of similar to the way that we are, and then they changed their mind and decided to not include it. The states that do have these types of policies are Texas, Alabama, Georgia, and Kentucky, if I remember correctly, and no other states. Emily, the group that I cited is TASH, and they have a very long report with some good points on why they were opposed.
So should we just move this to Ledge tomorrow? This decision? No?
Oh yeah, Alicia's put forth a motion, and Anna specified the exact language that Alicia's motion would delete. I'll go ahead and offer a second to that motion.
So it has been motioned and seconded that we remove on page 8, line 30, and page 64, lines 34 through 36, which would be the requirement for schools to include cameras in seclusion rooms. Zafir, is your hand up to discuss your thoughts and feelings about that motion?
Yes.
Excellent.
Okay. So coming from someone who has pretty fresh out of college and was looking into getting services, I'm very conflicted about this. Especially being autistic. Most of my siblings are autistic and some of them are nonverbal. And I can absolutely see it from the lens of like they break something or they have some sort of episode, or maybe they're in crisis, and that the video of them doing that is being used to try to put them down the pipeline, I can absolutely see that. But also I can also see if there's no cameras at all, like evil people are going to be evil regardless, right? If they want to do something bad, they're going to do it on or off camera. But my issue is that when the cameras when my issue is that if there's no cameras, they're going to do it harder, more, and more openly. The more that you do something bad, the more your brain is like, that's fine. And so I feel like it's going to become more commonplace, if that makes sense. Like even just like with me, I've been mishandled in situations like that where there weren't cameras. And because I am a child, no one's going to believe me. And I'm very, very conflicted about it because I see both sides, but both of them are kind of like pulling me on opposite directions. Like I just can't make a. Does that make sense? I hope I'm making sense because I just like
I don't know if you can see some of the parent advocates in the room are like emphatically nodding along with you, Zafir. So you are making sense.
Okay,
Yes.
cool. Because I've had situations where, for example, CPS, they would come and interview us, but they would have like parents in the room, right? And so like when I would try to reach out to them discreetly and be like, hey, that I can't talk to you because she's right there, right? They would be like, well, we talked to you, and so that's okay. If I feel like if there's cameras, I can be like, no, you can see this is happening right here. Like you have to believe me, it's on camera. But I can also see people be like, hey, this kid broke a table because he was in a moment of distress. Let's put him in jail, especially Black kids. I have almost gone to jail for petting someone's dog at a dog park. Not even joking. So it's like, I was 3, by the way. I just, it's really hard for me to feel strongly in either way because both have significant upsides and significant downsides, especially hearing from, oh my gosh, I'm new here. I forgot her name. Working in juvenile justice system and hearing how often, Sandra, there we go, hearing how often that's being used against folks who are just, they can't, like, maybe they have problems regulating, they can't help it, that's just how they work, like they can't, it's very, I can't even say it's frustrating, it's just very conflicting from the standpoint of someone who's been in both situations of there's no cameras, I can treat you worse, and there are cameras, so we're going to do it on the sly. So I just wanted to add some nuance and make that clear.
I appreciate that, Michael. I appreciate it. At this time, we are over time, so I just want to be clear. If someone could go over what's being removed, if we remove it today, then I'm not sure what the process is about going back over it. So we need to be very clear what's happening today. So someone put in a motion, it was seconded. So now what is the next step according to our rules?
It would be to work through the consensus model.
Okay.
We've got a motion, we've got a second.
Right.
To remove it. So, we can start to walk through that. I don't know if you want to do that, Annette, you want me to do it?
Why don't you go ahead and do it?
Sure, yeah.
Thank you.
So we've got the slide up, right? So we've talked a lot about the racial equity impact. That's how we got here, right? And so the racial equity worksheet's been done. So now we're in a place that for voting members of the council, does anyone wish to block the suggested change to remove video cameras? And I don't have the language, sorry. Anna, could you give me that language again?
Sure. To block the removal of the line 30 from page 8 of House Bill 3835 and lines 34 through 36 of page 64, which would require school districts to put cameras in rooms used for seclusion.
Does anyone wish to block? Okay. Does anyone wish to stand aside? You can raise your figurative hand. So, Emily Cooper, Disability Rights Oregon, standing aside on this decision. Zafir Berry, standing aside on this decision. Adam Rodakowski is going to stand aside on this decision as well, because it is quite complicated for me. Emily or Zafir, do either of the two of you have any comments beyond what's already been said?
I don't know if I have any other comments. It's just it feels like it's a very tough situation, you know? And I feel like, you know, having it's hard to describe as someone who's had both the presence and absence of cameras be used against them. So for me, I cannot agree whatsoever with having it removed, just because I can't, I don't know, if I'm not at least like 90% into something, I can't 100%, I can't agree with it. I can't even agree with reservations. Like I have to know that what I'm doing, which is a significant decision, is going to go the way that I feel like would best help people. And right now I just don't. I don't know.
Yeah, and that's completely fair. Thank you. I appreciate you sharing that. Do I have April Flint Gerner standing aside? Is that correct, April? Okay. Ebony Clark is standing aside. Carissa Cousins is standing aside.
Can I just ask a quick question?
Yeah.
How hard would it be to, if we say, okay, we're not quite ready for this, how hard is it to get it added in later once we get more research and figure out the pluses and minuses and get more input? How hard would it be to add that back in if we were to take it out now?
Great question. It would likely take a new bill, and somebody else would have to run that. It might not go this session. It's something that could go in the short session. But I think once we take it out of this bill, it would be difficult to put it back into this particular bill, especially with the outsized fiscal impact that this has.
Well, with that noted, Carissa Cousins, are you standing aside?
Yeah, I think I'll still stand aside on that. It's
Okay.
tough.
Alicia Overstreet, standing aside. Okay. Any of the other folks that I called standing aside, do you have any comment beyond what the discussion's already held?
Yeah, this is Ebony. I've just found myself wondering, is it that we need more information? Is there a little bit more discussion? I guess I'm just wondering, are we 100% ready to vote? Is it that, at least for me, let me use I statements. I find myself just wanting to know just a little bit more about the data and, what reports, speak to, cameras not having, any impact in a positive way. I just think I can hear the concerns on kind of both sides, and I just feel like I need a little bit more discussion to really land on where I stand on this. And so I just feel like, honestly, I'm not ready to vote yet.
Noted. Okay, and then I see Patty Mosley standing aside now. It looks like we have some additional hands coming in. Allison Stark standing aside. Any other comments?
Yeah,
Um,
this is. Go ahead, Alicia.
oh no, you can go ahead.
So I'm just noting that Alicia made the motion, and we have a lot of people standing aside. I'm wondering if maybe we could have a friendly amendment to the motion saying that we are recommending consideration of removal of that. The legislative process happens kind of fast. I don't want us to be locked into something that there's so much uncertainty about. So I don't want to have us locked into keeping it. If the vote fails, but there's a lot of people who have a lot of reservations, including the person who offered the motion. So just maybe would we be better off if the motion were to recommend evaluation of whether that needs to be removed?
Or do we wish to rescind the motion?
So I'll make a statement regarding why I made the motion. Again, I was led by kind of the full conversation and input from family members who have very similar concerns that Sophia had mentioned. So I think on that standpoint, the fact that we have youth and family members, saying the same thing pretty much, that, we can see that that having video, particularly with audio, can be very helpful. And also expressing the concern that we are worried that it might actually be used against our kids or against youth in school. That's one of the reasons why I actually brought the motion. And since I brought the motion and I can see all these discussions and the comments made, the additional comments made after the motion was made, I move to retract my initial motion, and in the hopes that we can have more conversation about this, and perhaps that needs to be tomorrow during a legislative committee meeting. But I don't know what else do I need to do other than me retracting my motion that I initially brought.
I think that's all we need. I mean, we don't follow Robert's Rules of Order or anything super strict like that on this council. So I think that is all we need, is retract the motion and then offer up to anyone who would like to bring in a different motion, or again, we don't have to have a motion to just continue the conversation tomorrow.
Yeah. I want to plug that in, and really, even if we, at some point take this out, if we do end up voting to get this taken out, I really want to ensure that the council has more conversations about this with all of our system partners and families and youth, family members and youth who have that lived experience with the restraint and seclusion, particularly restraint and seclusion of our kids with disabilities.
Okay.
Thank you, Alicia.
I see we got Robin and Zafir, and then I think I'm gonna close it.
Yeah, I just want to remind everybody, this is great that we can continue this tomorrow in our 1 hour legislative committee, where we also have other amendments that we need to discuss that have come through that we're not going to discuss today. But I just want to set some expectations with everyone that we're not going to be able to spend an hour on every single amendment. We're going to need to divide up our time very carefully and thoughtfully. So that's part of what we're going to have to do tomorrow. I would encourage you, understand that there's not a lot of time to engage in a lot more research or a lot more other types of things. There's not staff support to do that. So if there are spaces that are like this, where, as April says, can we consider a may clause with the addition of study or additional data. Those are the types of things that we need to be thinking about. But the reality is, in something this specific and this, like this, we're not going to be able to take an hour tomorrow. So I just want to set everybody's expectations because we do have a number of amendments to discuss. Thank you.
Kati, I'll give you the last word.
Thank you. I think that Carissa and Ebony kind of maybe for me describe the path forward. I'm concerned about it being in there because we don't seem to be sure if it is potentially more harmful or more helpful, like where on the scale it falls. I would be more comfortable giving it the time it needs, and even if that means it's an addition to the next session, to make sure that we don't get it wrong in the time constraint that we might be, to Robin's point, needing to examine it in. So I offer that. To me, after this conversation, it very much strikes me that the risk of harm is high enough that I can't necessarily lean on the belief that it would do good yet, because I don't have, to Ebony's point, enough information about it. So I just wanted to offer that as a perspective on a path forward.
Thanks. Yeah. And so we'll move it to legislative subcommittee. What I want folks to understand and know as we make decisions like this, that is, regardless of which way we end up, there will be an event where there is likely a negative outcome as a result of our decision. And so we do have an obligation to really think this through, right? And try and do what we can to make the smartest decision that we believe will be the best for children. And so I appreciate the discussion. I feel the weight of the decision. And don't want to make a decision that has a negative impact. So I appreciate the discussion today and all of that. So we'll move that till we've got a report and discussion about the whole bill now. So we've got we've got till almost 4:30. So I know that Robin, who's our legislative committee chair, is going to help kind of guide us through some of the updates on House Bill 3835. She may call on Michelle Pfeiffer or Anna Williams, who have been doing a lot of the day-to-day work on this, to help with the review as well. So, Robin, over to you.
I believe I'm going to turn this to Michelle to drive, correct? And just give us some big overviews on what are the things that really changed between when we voted on this bill and now, because I know there have been a few tweaks and changes and things that have come out. For instance, the IM medication.
Yeah, I'll do my best. I'm sorry, this was a bit of a late request. I'm feeling a little bit unprepared for this, but happy to jump in to the best that I can. I believe that you all have received, different versions of red lines of what has been submitted along the way. And so that's part of what I'm not sure, how far back do you want me to go to what's changed, Robin?
Just the big things. I think, okay. One thing to note for people is that in the original version that we voted on, there was language in there allowing for intramuscular injections in skip and SAPE and some of the other types of facilities like that had 24-hour nursing. That has been removed from the bill. And that was done in consultation with the Department of Justice, that we couldn't get to language. That has been removed from the bill, and that is something that will either come back another day or it won't.
Okay, I can jump through some of these other ones. We also aligned the definition of chemical restraint that's used in Section 1. Chemical restraint, just as a reminder, is a component of what is the definition of child abuse involving a restraint. So when we define chemical restraint, it is for the purposes of understanding that it is a component of child abuse. We align that definition with CFR. Gosh, if somebody could put in the chat what CFR means, that'd be great. specifically CFR for the condition of participation for the use of restraint and seclusion in psychiatric residential treatment facilities, providing inpatient psychiatric services for individuals under 21. Happy to paste this into the chat if it will allow me as an outsider to do so. So that is kind of what we've used in trying to align our definitions with Medicaid requirements. And so that definition of chemical restraint that's in the bill was changed to align with the spirit and intent of this language in CFR. The other kind of big broad changes, yes, the intramuscular medication was taken out. We also shifted, after doing additional research, from the definition, the threshold definition of severe harm, and instead shifted that to serious physical harm. And that is in alignment with both the Joint Commission's recommendations as well as the Department of Education's guidance to schools on that threshold for the type of severity or concern of imminent risk of what type of harm, maybe serious physical harm there.
Michelle, you might have just responded to this, but question in the chat about is immediate also in that?
Yes. And I don't know if I'm presenting on some of our additional recommended edits later, but I'd be happy to also talk about some additional ones around that, but big things that have already gone into the bill. We also did a lot of aligning of language between schools and our child and care statutes around the specific words that are used around prohibited restraints, time requirements for certain actions, and specifically the schools had a clarification on what is not a mechanical restraint and adding that into our child and care statute. So there is alignment verbatim when you look at both statutes, so there's consistency across both settings. I think the other big things that were done around schools is there was some statutes that were completely repealed because the changes to the definitions really made them unnecessary to have all sorts of caveats for not substantiating staff in specific situations when they were more like violations or systemic concerns rather than directly about the staff's behaviors or actions towards a child. And so just removing those reduces a lot of confusion and nuance in those investigations. And this really right sizes if a staff member in a school's behavior is child abuse, that they will be issued a finding of child abuse. And when there are other violations of statute, those will be handled in a regulatory fashion. I don't know if there's any other really big pieces.
Yeah, no, I think those were the ones.
And I'm sorry if I am missing any of them. That's not intentional.
Couple of things that we had discussed. Oh, sorry, somebody's knocking on the door. Trying to manage a whole bunch of stuff over here. Couple of things that we had discussed in this space or in our legislative committee space that are not in the bill. We had a lot of discussion around including school resource officers under the definitions of prohibited seclusion and prohibited restraint because school resource officers are so often involved when there are aggressive behaviors being used at school. After digging in on the statutory requirements, school resource officers are governed under the law enforcement use of force statute and would have been very messy and challenging and also kind of creating the same problem we're trying to solve here in terms of creating two different sets of statutes that govern the same kind of behavior. And so SROs are not included in the bill, even though the expectation is that all school employees are. So like, it's a little bit complicated, right? But I wanted to call that out as one of the particular challenges that this bill was unable to resolve. with the number of hours of conversation that went into that particular topic.
There's a comment from Alicia in the chat. Before we move from that, anybody have anything on what Anna just said? Okay. So the comment in the chat is from Alicia. So the definition for chemical restraint is in line with this, quote, a chemical restraint is a medication used to control behavior or to restrict the participant's freedom of movement and is not a standard treatment for the participant's medical or psychiatric condition. Is that accurate?
And then Michelle responded back with what is in the bill, which is chemical restraint means a medication that is administered to a child to control the child's behavior and restrict the child's freedom of movement other than medication that is standard treatment. So, I mean, yes, there are different words, but the words mean the same thing.
I don't think the words mean the same thing. I don't think other than and is not a standard treatment. I think those are very two different things. Very different things. Because other than,
I don't see the difference, to be honest with you.
well, other than would basically include, allowing prescribers or providers to utilize, medications that are written for as needed in a more liberal way than, the other definition would. So for example, if I have a medication, let's say it's, I don't know, hydroxyzine, right? Could be used for anxiety, but it could also have a sedative kind of outcome, I guess. So if it says on the bottle, use as needed, whoever is looking over the child or the youth can utilize that medication to then essentially chemically restrain the child or the youth, because it is not necessarily just to give it to them for anxiety, but you can also utilize it to control or restrict their behavior because of what the medication is there to do. Now, if you were to say that, were to use a definition and is not a standard treatment, then the person who's giving the medication to the child could not use that as basically an excuse to give it to the child to control their behavior. So that is where I'm very concerned about the difference in the language here. Yes, we might say that it's the same thing, but it clearly is not the same thing.
So I think I have a couple of kind of questions or comments about this. So this was language from LC, correct? From Legislative Council?
That's correct.
Okay, so
He asked for it to be in alignment with that statute without citing CFR specifically.
Yeah. So I just want to be clear to folks that we did ask for that language. It was Legislative Council that brought it back the way it's written. So no one on this call has control over what Legislative Council decides to write or does not write.
I don't remember us talking in Legislative Council about changing it from and as not part of it to change to the other than. I don't remember us talking about that, because I remember us having that.
That's what Adam's saying. We didn't talk about it. We asked her to put it in alignment with CFR without citing CFR, which was the discussion that we had.
And I want to make sure, I think Adam was referring to Legislative Council, which is a certain position within the Capitol that does the drafting of the language. And so I apologize that I had not seen this specific nuance, and I don't think there is disagreement that we want to align with CFR. I'm happy on behalf of ODHS to submit this as a recommended change to align with what you put in here, Alicia.
Yeah, so like it wasn't us, is my point, Alicia. It's not like anyone in this discussion has any sort of issue with that language that you put. It's that once we send the request over to Legislative Council in the Capitol, they then do whatever they like. And they're typically attorneys, right, that are writing these and looking at other pieces of law and where definitions exist in other places. And so, I don't think there's disagreement here. Like I hear the concern expressed by the language that Legislative Council put in. I think the intent of all of us is the same.
Right. So I guess I'm not understanding, like, if we are the ones, right, in partnership with ODHS bringing this forth, I'm trying to figure out why a third person can just say, never mind, we're gonna just write it this way. I guess I'm trying to figure out where that
I hear you.
comes from.
I hear you. I
Do you want me to try to answer that, Adam?
Yeah, you can. Yes, go ahead.
So, Legislative Council, they are the lawyers that work for the legislature, and they are the ones who put the language for, we tell them what we're asking for, what our intent is, what our goals are, and they say, this is the legal language that most closely will get you to the intent that you have expressed to me. So the request that we made was to mirror the Code of Federal Regulations, which is what CFR stands for, regarding chemical restraint without specifically citing them. That was the language that she gave us back, saying this means the same thing in legal terms. And she is the lawyer who writes the laws that she wrote Senate Bill 710, she wrote Senate Bill 1515. She knows this stuff inside and out. She's the one person in Legislative Council, the legislature's lawyers, who has lived this policy work. And so that's what I can tell you. She is the one who understands all of these different laws and how they have overlapped and intersected over the course of time. And she gave us a lot of we did this a few years ago here, and it lives over here in this place, right? Like there was a lot of conversation about the impacts of the words that we're choosing and how they would impact other bills or laws currently. And she is an expert. And so I personally as staff would recommend to the council that we trust that her legal analysis is accurate to the extent that we don't know how I don't know better that may or doesn't, I can't make that argument from a legal standpoint, but she made that recommendation to us. So that's some context there to hopefully help understand what is LC. That in this case it's Legislative Council, and this particular legislative counselor has been the one who has lived in this policy space for years.
Yeah, and so that's why I say, Alicia, I think we are all in agreement that and our intent is all the same. I don't think there is anybody trying to sneak one past any of us. I don't fully understand LC either. Why does that exist that way, Alicia? I also have that question. So I don't. The process is frustrating.
I'm just throwing it out there. I just wanted to be on record that I very clearly think that the wording, those two wording or types of wordings are very different in their intent and in the way that it could be executed or implemented. So I understand that, that's the lawyer and, she's the expert and she knows all the things. Got it. I get it. I'm, just a family member who is very concerned about the language in this bill. Also mindful mindful about the fact that some of this work is something, or this work is actually something that I've had to learn in my in my studies as well. So I just want to be very open and frank about the fact that I do not think that those two that the phrasing of those two are the same or will have the same impact. And I understand that it is illegal to force medication on a youth. That doesn't mean that it doesn't happen. So just like, certain restraints and certain types of seclusions are technically against the law and illegal, still happening though. So, right? I mean, we can say that something's illegal, but it doesn't mean that it's not going to be done. So I just wanted to be very open and frank about that concern. And I'll leave it at that. Appreciate it.
Yeah. So Michelle just dropped in the chat Michelle, can you correct me if I'm wrong, but that is what we submitted as a request.
No, sorry. This is what I am happy to talk with legislative counsel if I'm allowed to with requested amendments and make this abundantly clear that we want this language to be this specific.
Gotcha. Okay.
Happy to put that on behalf of ODHS.
Jenny.
Yeah, I don't know if this has been part of any conversations, but I'm over here thinking from my own lived experience with my son, who would be, say, he was in an ABA hospital setting where he was being restrained for hours and hours at a time and fighting back. And then they would end up giving him a shot of lorazepam. And so I'm over here like, is there any language in there about because for me as a parent, he was better off having lorazepam than being held down for hours and hours at a time. So there is some nuance there. I'm very against chemical restraint, but is there any language around protecting a kid from restraint and seclusion because you give them an anxiety medication? It's complicated.
I would defer to if there's any psychiatric professionals in the room to answer that question.
Or if language could be added in to, include those kinds of situations.
I'll speak from my personal experience in seeing that gray area misused at Northwest Behavioral in Portland. And so I have specific concerns as a person, not on behalf of ODHS, but as an investigator, that I think there has to be a pretty specific line there that nothing that is going to be used to restrict a child's movement or sedate them in any way is used as a response as behavioral intervention.
But if they're being restricted and restrained because they are still fighting back and fighting back and fighting back, they're already being restrained. Yes, and you're trying to stop the restraint. So it's, yeah.
Yeah, that was the case in Northwest Behavioral, and they were using chemical restraints. I think it was Halidol is the medication, which abruptly sedated the youth to not have to be involved in a restraint and free up staff. So it was used really as a convenience more than it was used as something, therapeutic isn't even the right word, but with that spirit, I guess.
Yeah.
And I think it's not really what Jenny's saying, right?
Oh,
Jenny's saying sometimes you have a kid who's so activated that they're getting restrained and restrained and restrained physically, and that is itself traumatizing. And so there's some complicated nuance to the clinical decision making that sometimes may need to take place to say, okay, we're going to restrain this poor kid there. And so is there a time when a chemical intervention is a more humane way of solving that problem for that kid? Jenny, is that an accurate rephrasing?
Yes, if they're actively being restrained and maybe if the language could for a certain amount of time and they're not relenting because they have a feisty spirit and they aren't going to comply, and not Haldol, but a lorazepam or something, because those are different medications as well, Haldol versus lorazepam. But anyway, that's the only, I have lived experience with that. So I just thought I would bring it up.
Thank you,
Thanks, Jenny. And I saw you unmute. I don't know if our child psychiatrist has anything to say.
I see the use of a medicine like that in line with standard treatment for the underlying medical or psychiatric condition, because I, as a clinician, a physician, in that situation, will be thinking, well, significant anxiety is driving this behavior, and actually treatment with medication would lead to a much greater likelihood of the patient being removed from physical restraints. That's much different than using, I mean, there are medicines. I mean, I tend to think of medicines like dexmedetomidine that are used in our ICU, which can sedate patients very quickly, or nasal Versed, or just other medicines that are totally used for quick ketamine, for quick immobilization, which we do not use. We would use medicines like benzodiazepines, such as lorazepam, or antipsychotic medications that were being used to treat severe anxiety or psychotic symptoms.
So am I hearing you, Kyle, essentially saying that what Jenny is describing would be similar to what is in practice?
Yeah.
Okay. Yeah, I mean,
So that would be discussed with the care provider too.
So
The parent.
So it sounds like current practice is in alignment with kind of Jenny's preferred response or ability for providers, at least in a
Yes.
hospital setting, to respond.
Yes. Yes.
Okay.
And that's an important clarification because that is only in a hospital setting.
Only.
You know, as Jamie's pointed out in here, if the child does not want to take the medication, even if it's in their standard care plan, even if the parent would like to administer it, that is not allowable in Oregon. And that will not change with this law. In a hospital setting, it is a different story, and hospital setting is not part of the conversation. But in hospital settings, we can't do chemical restraints. We don't do chemical restraints. It's my entire career, I don't think we've ever done chemical restraints.
Zafir, you had your hand up.
I did. I think I had a question and then it was gone and then it came back and then it was for a different thing. And so I was like, I'm just gonna keep listening and see if maybe it gets clarified. I think for me with the first part of the conversation, where Alicia was talking about the how it was written, I think I'm pretty that got clarified. I'm pretty sure it's like you can't, if, for example, Adderall, right? I know there's more like types of medicine, but that's one that like a lot of people get and it says as needed. I feel like if you would give that to a kid, that as needed means as needed. So if the provider and the person are like, hey, I can't focus, I need my Adderall, giving them their Adderall wouldn't be, I mean, it's as needed. Going back to what I said earlier, horrible people will be horrible regardless of anything. So if they're trying to restrain the child illegally, they're just gonna do it. I feel like an as needed medication is a different situation.
Yeah, and it's the as needed part that I am concerned about. When we're saying that other than part of, or oh geez, I know, Michelle, you put it in other than medication that is a standard treatment for the child's medical or psychiatric condition. It's,
Yeah, well,
I think it's that as needed part that makes me concerned about that wording in itself.
but then wouldn't it be illegal to give them anything other than their as needed medication?
No, no, that's not, I don't think that's what I'm saying.
Okay.
I think what I'm trying to say is that if you have a medication that reduces anxiety, I guess, right, or makes someone calmer. One of the ones that I know of is hydro, which is technically used, or it's an antihistamine, but it can be used for anxiety, and you can use it as needed. But what it does, what it can do, is essentially make a person, less activated, I guess, less active, less, I don't know, Dr. Johnson, how would you describe it? But it's the I'm sorry, I didn't mean to interrupt.
Oh, no. Please keep going. I'm covering the Oregon Psychiatric Access Line for Kids, and I'm getting told that a call's coming, so I'm a little distracted. So I apologize.
Okay, no, go ahead.
Call is coming at a bad time for me. I might see if somebody else can take it. Keep going.
Okay. Yeah. So basically, like the hydroxyzine, which is, an antihistamine, we all know what happens when we take Benadryl, right? We get really tired. Yeah. So that is, I think, what I am concerned about is the use of things like Benadryl, hydroxyzine, and things like that when you have a facility or provider who is just exhausted and cannot take it anymore. And it says here, it technically is part of their medication or their treatment, right? We can just give this to them and say, hey, I think you are really, anxious. So the person or the provider can, what I'm worried about is the person or the facility and the provider potentially coercing the youth into taking that medication in order for them to then not have to deal with those big behaviors. That is what I mean with what my concern is with the other than medication that is standard treatment. And I appreciate Michelle offering, to take this to LC and then see if that language is doable.
I don't know. I guess for me, maybe I'm getting caught up on the wording. So it's a part of their care plan and it says as needed. You're worried about that being abused. The as needed clause being abused and just being like, I don't want to deal with it. We're going to give them this.
Yes.
But then to combat.
Oh, sorry. Go ahead.
No, go ahead. Go ahead.
Bad actors are going to be bad actors regardless. And there's no law that's going to protect all of us from bad actors. My daughter has asthma and she has an inhaler that is given as needed. It's notified as PRN as needed. And when she was in middle school, some school nurse decided that she needed to take that medication every day at 4-hour intervals because that's what it's prescribed for, not when she needed it for having an asthma attack. The impact of that is remarkable. I mean, really, seriously, it's absolutely terrifying and horrifying. And it took us weeks to figure out that what was causing anxiety attacks was some school nurse deciding that somebody needed albuterol, not as needed, but every time that it was scheduled. As needed is a very common medical. I take ibuprofen as needed. I have other, medications that are as needed. But if we're looking to regulate staff's ability and regulate their intention to not take advantage of the system, we're not going to be able to do that. We're never going to have a perfect bill, and we're not going to be able to do anything at all. Bad actors are bad actors are bad actors. And I don't know how to fix that. But what I do know is that the thoughtful providers that I've worked with in this state, and I've seen some bad actors and they've gone out of business and they're gone. But the thoughtful providers I work with really do come with that intent of caring for individuals to get them back to a safe environment as soon as we can, and we need to give them the tools to do so.
I guess that's where I'm coming from. Like if it's, I don't know. I feel like, and if they misuse it, then that's a whole different situation. I feel like as needed doesn't give them the leeway to use it whenever they want to. I think it's more like, hey, I feel like I don't know. I maybe I don't know what I'm trying to get at here, but I feel like
I'm just
like
gonna
with-
sorry,
yeah.
Sophia.
Go ahead.
I interrupted you. I take it back.
No, it's
We have
okay.
about 5
I'm
minutes
doing a
left.
time check. Yeah.
We have about 5 minutes
Gotcha.
left. We have Adam's had his hand up for a while, so I want to go ahead and let Adam speak here for a
Yes.
second.
You can skip me. It's cool. Don't worry about
Okay,
it.
thank you. Jenny, go ahead.
Yeah, I mean, like I put it in the chat, the exact situation with my son. He had been restrained for hours and hours, and he was not calming down. And they gave him a shot of lorazepam, and then they were able to take their hands off of him. I am not a proponent of chemical restraint, but is there a way for language to be added in for this very specific situation when a child is either going to be held down for hours fighting for their life or given lorazepam? Because in my experience, it was much more traumatizing for him to be held down for hours at a time. And like language about if the child has been restrained for this long and it is not, and they are, I don't know if it's possible, but that's kind of what I was trying to get at.
Kyle, you want to respond to that, and then we'll go back to
Yeah,
Zafir.
I hear you, Jenny, but I think that we're covered by the fact that it would be a medicine in that situation would be used to treat the underlying problem, the underlying psychiatric condition, which would be severe anxiety.
And that would be
So
as
I
needed.
don't think you would need to have in statute the specifics of that situation in statute.
Zafir, you get the last words.
I do. I already said I was done. I was responding to Emily in the chat. That was just my 2 cents about the wording, because again, bad people are gonna be bad regardless. I don't feel like as needed gives them leeway to do it whenever they want to. I think that's just as someone who's done like a pharmacy background thing, you just put as needed so that they know to use it as needed. It's just a medication thing.
And on that note, we will pick this back up at the Legislative Committee tomorrow morning. Adam, Annette, I'm going to turn it back over to you to close out our meeting.
All right. Thank you, everyone, for attending today. Few housekeeping things, tribal engagement with strategic plan. And we have, hopefully will be scheduled fairly soon as the public meeting law training opportunities as well. Also, our next meeting, which is in April, is set for in person. Is that correct? At the Portland State Office Building from 12:30 to 4:30. So an opportunity for us to meet and greet one another and dig right into this work again. That'll be on April 1. And is this a hybrid meeting?
It will be if it has to be, but we are
Okay.
trying not to promote it as such because last time we did that, only 2 people showed up in person.
Okay. All right. Good deal. All right. With that, that is the end of our meeting. Thank you, everyone, for attending.
Annette, is it okay if I click back to the tribal engagement? We didn't get to actually see the content for that.
Sure. Go ahead.
So the System of Care Advisory Council strategic plan, we have tried to do a formal tribal consultation process to make sure that their perspectives and priorities are included. We've not been able to get that to work. I think there's just like a heck of a lot going on in terms of those different processes and communication streams. So we are asking our agency partners who have tribal relations and connections, as well as any of our committee members who have human relationships with folks who do work on behalf of the tribes, within the tribes, to tribal members, to let folks know that their voices matter, that we want to hear them, that we will create a process if there's a way that they say, this is how folks in my tribe want to be engaged, or this is how folks who do the kind of work I do on behalf of tribes want to be engaged. We want to know about it. We want to be responsive to it. We have had a hard time even getting that question to the folks who could answer it. So we are asking for the resources of the council to help support us in getting through. If the tribes don't want to participate, that's fine, but we want to make sure that they know that they are very much invited to the table. Or we will go to theirs. I guess I shouldn't say invited to our table. We're happy to go to their table or whatever other location they would request we come to.
Absolutely. Thank you, Anna. And with that, that is the end of our meeting. Again, thank you, everyone. Hope to see you at another table or especially at our meeting April 1. Thank you.